Morning, everybody. Welcome to this online CME series being conducted by the Kerala Society of Ophthalmic Surgeons. Let me wish you all a very happy Onam. And this is the 18th in the series. And as you all know, the topic is NABH. It's a very important topic, and I'm very happy to have stars of speakers in this session. This session has been designed into such a way that we have three prominent panelists and two sessions, one on entry level and the other one on ECO. The entry level will be managed by Dr. Chandrasekhar and ECO by Dr. Nirmal. They are expert in that field. And this is a project of our president, Dr. Meena Chakravarti, madam, and it is with the aim to help all the KSOS members who are interested in getting the NABH accreditation. And yet another project of madam is NCD and NCED, that is non-communicable disease and non-communicable eye disease. So these awareness program will be inaugurated by our governor, Sri Arif Mohammad Khan, on 1st September at 11 a.m. It will be streamed live on YouTube and Facebook. I request all of you to join us on that wonderful occasion. And it's going to be a month-long awareness program for other specialties and as well as for the public. So before I go into this program, let me tell you that there are about 8,000 hospitals in India which has got NABH accreditation. And there are so many people waiting for it also, and it's going to become a new norm. So it's not a joke that everybody has to become serious about it and learn. And this is just a sensitization program. 2 hours, you cannot cover the entire NABH programs. And so let's begin with this program. So before we go into the program, I request our president, Meena madam, to just address us and to introduce the three eminent panelists, namely Adiyar sir, Mohan sir, and Shashi sir. Over to you, madam.
Thank you, Rajiv. Respected dignitaries on this virtual dais, my dear friends and colleagues. First of all, let me bring you Onam greetings from God's own country. A warm welcome to each and every one of you attending this program, which I thought was a very, very relevant program which our organization should have, taking into account the fact that the Clinical Establishment Act has become a ground reality. So this program is basically meant for the ophthalmic fraternity in Kerala, as well as across the country, to gather pearls of wisdom to kickstart the NABH accreditation process. I was also very personally speaking from my own personal friend, I was really interested because my organization is also going through the process of getting accreditation. This CME series is 18th in the series. We started as the lockdown lectures and moved on to the Ksos CME series. This is the 18th one. Every Sunday we join together, have a good program in action. I take this opportunity also to invite each and every one of you to the inauguration of the NCD and NCED awareness campaign, which is my presidential project. We are kickstarting the project on the 1st. The KSOS spearheaded initiative to create awareness in the public on non-communicable diseases and non-communicable eye diseases. The Honorable Governor of Kerala will be inaugurating the program. I invite each and every one of you, please consider this as a personal invitation to participate in that program. Let me take this opportunity to introduce the panelists of this CME series. The key panelist, Dr. R.D. Ravindran sir, he requires no formal introduction. He is well known to all of us. He's the chairman of quality control at Arvind Eye Care System. He has seen 9 of his hospitals achieve entry-level accreditation, and 4 of them are also in the process. He was also one of the key representatives in formulating the eye care organization standards for NABH. Welcome, sir. I take this opportunity to welcome Dr. P.I. Mohan, past president of the Kerala Society of Ophthalmic Surgeons and the superintendent of the Muthoot Hospital, who has seen his hospital getting accredited with the full NABH accreditation. He is also the internal auditor for the KSOS and the chairman of the Low Visual Aid Project. Welcome, sir. I welcome Dr. Shashi Kumar, past president of the Kerala Society of Ophthalmic Surgeons, He is a senior consultant at the Kochi Eye Care Center in Alva. He has been in all positions in KSOS, from editor, secretary, and president. And his words of advice are a source of inspiration to us. Welcome you, sir. I am sure we'll have a very good discussion today, and all of us will kickstart our own hospitals to get NABH accreditation. Again, I welcome each and every one of you. Thank you.
Thank you, madam. We'll move on to the session without any delay. And let me introduce the moderator of the first session, Dr. Chandrasekhar, a very good friend of mine. We had been friends for 46 years now. He's also a KSO's member. And he's presently the consultant at Aravind Eye Hospital, Coimbatore, and he's a certified NABH assessor. He's been instrumental in getting accreditation for more than 10 hospitals around and many branches of Aravind Eye Hospital. So I'm not going to go more to that, and I invite Dr. Chandrasekhar to take the proceedings. Over to you, Chandrasekhar.
At the outset, I'd like to wish all of you and your family happy Onam wishes. It's really a good day to start this program. And I would like to thank KSOS President, Secretary, and my friend Rajiv Sugumaran for organizing such a wonderful program. I don't think we have had any program like this before, a shorter version. So we have a list of panelists and speakers and organizers who are all some way or other in associated accredited hospitals or certified hospitals. This panel consists of 6 NABH assessors, out of which 2 are principal assessors, Dr. Nirmal and Dr. Gagan. And 5 of us here have represented in the NABH committee to form the eye care guidelines, eye care standards, for which Dr. Nirmal was primarily responsible. So some of the talks you can see have been designed so that they are not usually covered in the usual short versions like committees, code drills, KPIs, and so on. This is not going to be a training program. It is going to be a sensitizing program for those who are already in it to go to eye care standards and those who want to go for it. So with this short introduction, I would like to introduce the first speaker, who is Dr. Sunita Dubey. She is working in Shroff Eye Hospital. She's a glaucoma specialist of more than 25 years of experience. She had been a fellow at Wills Eye Hospital, Philadelphia, and she is trained in Lean Sigma. She was part of the NABH AAO's committee for setting up eye standards. So she will be talking about the entry level, why entry level, and what is the gap analysis you need to do. Over to you, Dr. Sunita.
Thank you, Dr. Chandrasekhar. I'll share my screen now. Okay. So is it visible? Hello?
Yeah, very visible, very visible.
Okay. So at the outset, I would like to thank KSOS for this wonderful opportunity. My topic today is why entry-level certification and the gap analysis. As we know, accreditation helps healthcare organizations to establish objective systems aimed at improved quality and patient safety. It has become the need of the hour since operational and service excellence have become demands by the patients and therefore the necessities for the hospital. And it can be achieved and sustained only by means of application of systematic methods and techniques. So NABH accreditation standards were developed in 2006 based on the principles that focus on meeting users' needs as the desired results. And initially the SHCO and HCO standards were developed, and there were some differences in the standards and the objective elements. The number of standards were less in SHCO as compared to HCO. And then eventually the ECO standards were developed, taking into consideration the specific needs for the eye care institutes. And then the clinic, blood bank, dental and nursing excellence standards were also available. So there are clear-cut benefits of accreditation for all the stakeholders in a hospital, like patients, staff members, and the hospital itself. First and foremost is the development of patient-centered approach in the hospitals, which is very important for improved patient treatment outcomes and patient satisfaction, standardization of processes and uniformity in service delivery, improved efficiencies and productivities. And if the hospital is accredited, there's an improved reputation of hospital in the community, and so the increased employee morale. And in the later stages, there is reduction in the cost as there's reduction in the non-value adding processes and increased revenue as a long-term benefit. Now coming to entry level, why entry level? A large number of hospitals face challenges and difficulties in implementing these stringent standards, especially in terms of infrastructure, manpower, and statutory requirements. The lack of knowledge, poor insurance coverage, and challenges faced by SHCO, which are more than 50,000 as SHCO in our country, became the roadblock for enhancing the level of quality care and for accreditation. And some of these, and even most of these hospitals, are not even having the basic minimal quality standard for patient care. So with the aim to encourage hospitals to begin and to join the quality journey as a stepping stone for enhancing the patient care and safety, entry-level pre-accreditation standards were introduced, and they were developed in consultation with various stakeholders. So NABH partnered with IRDA for this, and so that these standards can be adopted as minimal empanelment criteria, and these were made mandatory for providing insurance facility. So there are benefits to both the patients and to the regulatory bodies, as they provide access to reliable and certified information on facilities, infrastructure, and level of care, and provide an objective system of empanelment by insurance and other third parties. So basically, entry-level certification is the beginning of quality journey to a more advanced level, like progressive level, and finally the accreditation in a step-by-step and more practical, with a more practical approach. Now, NABH has also provided this very simple HOPE platform for the certification process. I think it's going to be discussed in detail subsequently, and it holds complete information about the simplified certification process requirements and compliances. So you just have to fulfill the criteria which are present in the on the HOPE portal. Just a brief about the standards. Entry-level standards, as I said, are easy to achieve and they can be sustained as they are just 1/4 of the full accreditation, and within objective elements of 149 for small healthcare and 167 for healthcare organization. And they're mainly focused on critical elements which are important for patient safety. So it's very, very important to maintain these critical elements to improve patient safety. Even if you're not going in for any accreditation, I think these critical elements are very, very important. Now coming to gap analysis. I think gap analysis is the first step in the quality journey. Whenever you're starting your journey in quality or accreditation, you have to first go through the gap analysis before doing anything else. And so it is basically the process wherein you visualize the difference between the reality and what is your target. So basically the whole process of gap analysis is to find the gap between the actual performance level and the desired performance level, which you set by setting a benchmark, which are available either internationally or given by the NABH. And one thing which is very important is that the hospital should not rush to the gap analysis process, and it may take a few days to several days to complete this process, as you need to cover each and every small detail of your facility, including the patient care services as well as the non-patient care services. And the gap analysis is based on these chapters, which most of us are very well aware. They are patient-centered chapters and management-centered chapters. So the gap analysis has to be done in reference to these chapters. Now, just coming to differences and between like what are the differences, how it has been made easy and to achieve and sustain, because there are less standard I just compared with the small healthcare organization, not with ECO, because it's going to be discussed later. So it is easy because the standards are less, the objective elements are less as compared to SHCO. And there are relaxation in various areas like OT criteria are not that stringent. Statutory requirement, there's some relaxation, especially in terms of fire, where you don't need fire NOC, third party certification is enough. Manpower requirement, especially in terms of nurses requirement, is pretty relaxed. Calibration, then indicators also, you can choose your own indicators, the 5 indicators. There's no specific indicators as given in the other accreditation. It's not required. So it's valid for 2 years, and then you can progress to the next level. As we know that NABH is all about documentation, implementation of standards, and providing evidence that you're doing the right thing. Unless you document, it's considered that the things are not being done. And for proper documentation and implementation and showing the evidence or assessing your own process, NABH has provided with this NABH toolkit, which you can just score yourself, and this is provided in detail for each and every chapter and the standard and objective elements. So what in gap analysis, in entry level, you have to just check the critical points, whether you are complying with these areas or these parameters or not. So statutory and regulatory requirements, I think these are the mandatory requirements. And depending on the facilities available in your organization. So these are the important licenses which you need to ensure. The MOUs, if you have outsourced services, then documentation, I think, is very, very important aspect. So the indicators or monitoring processes, so medical record for completion, availability of records, discharge summary, retention, safety, OT records, including registers, culture reports, temperature, humidity, then autoclaving, infection control, and hand hygiene. There are some relaxation in infrastructure and facility, but you need to ensure that you are having proper fire safety equipment, and the mock drill you are conducting, and preventive maintenance of equipment, etc. Then you have to display some, the scope of services, signages, patient rights and responsibilities, and so on and so forth. And another very important aspect, the training, conducting training, and also maintaining the records of training. So you need to ensure that you have proper records of your trainings, including BLS and CPR training, fire training, SOP training, infection control training, and training on common hospital policies. So I think these are the minimum thing. As we go on, we will discuss them in detail. And it's very important, and once you have done the gap analysis, you have to repeat the process again and prepare a detailed report, scrutinize the report, and make a list of all the gaps or deficiencies, and then plan a course of action to rectify the deficiencies, implement the planned course of action to bring improvement in the processes and functions. So this is basically a PDCA cycle wherein you're implementing, you're improving, and again you're checking and improving again till you achieve your benchmark. So just to conclude, gap analysis is very, very important before you proceed to the next step. And one thing here I would like to comment is that whenever you're taking an initiative for quality, establishing quality assurance or establishing accreditation, I think you need to have leadership. It should be the vision of leadership, and you need to promote the culture of quality, which should percolate down, and encourage participation of each and every staff member of yours so as to make this initiative of quality and accreditation successful. Thank you very much.
Thank you so much, Dr. Sunita. I think it's a good opening for people to understand why we need to go for NABH and who need to go to entry level. and the gap analysis, which is primary for the management to decide when to go and how to go and how much they need to spend. Thank you so much. The next talk is going to be a very important talk about SOPs. All these consultancy services get money by copying from one hospital to another hospital. There have been occasions they've copied other industry SOPs to the hospitals also, and the hospitals didn't bother to open it up. So Mr. Gautam Kumar is a manager of quality assurance at Aravind Coimbatore. We together have been implementing NABH in many hospitals, and he is got masters in hospital management and a fellow of high hospital management at Lyco Madurai, work experience of over 8 years at Aravind Eye Care System. Over to you, Mr. Gautam.
Thank you, sir, for the introduction. So at the outset, I would like to wish everyone a happy Onam. And I would like to thank the President, Ksos, and the Chairman, Scientific Committee for giving me this opportunity to talk on a subject that is universally applicable irrespective of the sector or industry. That is creating standard operating procedures and implementations. So the focus of this presentation will be what is an SOP, why do we need them, how do we implement it, and what are the benefits we are likely to derive out of. From an NABH perspective, the central focus around which this webinar is based on. So SOP is an established or prescribed methods to be followed routinely for the performance of designated operations or in designated situations. So most of the times what happens is whenever we want to bring in a system change or a policy change, we have meetings and decide on protocols. But when those protocols are communicated only at the oral level, the implementation becomes haywire. And hence, we need a written document, which becomes a guidebook, which can be used by everyone to ensure the standard processes are followed. And with all of us being in healthcare, it is even more important that we have standard operating procedures in place to ensure that we provide safe and efficient care uniformly. So this presentation, why is it more important? As I said, it is based on NABH, and whether it be the entry-level standards or the eye care standards or the full 5th edition standards. So one thing that we commonly see across all of them is the text highlighted in the red box, which states that this implies that the objective elements require documentation. So NABH has made it very clear that documentation is the key and without which we cannot proceed. So even in the HOPE application, which is now the single source of platform for applying for entry-level certification, there is a separate tab called documentation, under which we need to upload a handful of documents, which will be assessed by the desktop assessor. So for an SHCO, we need to upload around 16 documents, and for a healthcare organization, we need to upload around 21 documents. So creating an SOP. So there are few steps which everyone needs to keep in mind before actually starting this process. So the first one being begin with the end in mind. And this is one of the 7 highly effective habits of effective people stated by Stephen R. Covey. So we should know exactly where to start and where to end. Only then we'll be able to create a concise SOP. Then we have to choose a format. An SOP can never be a wayward format. It has to be structured with proper numbering and format. And all the SOPs which we create has to be in similar formats. Then we have to ask input from the process owners, process doers, stakeholders, because at the end of the day, it is them who's going to be implementing what is written. Write an unrealistic SOP and expect them to follow it. Then we have to define the scope, and we have to identify the audience because they are the one who are going to read it. So it should be understandable by them. Then based on all the above points, we write the SOP, and after getting implemented, we review it, test it, edit it, repeat it. So the important factor here, which we need to be very cautious about, is the first version which we create need not be the final version. There will always be multiple revisions, changes, and it will take a lot of time before we get that one final copy in hand. So it requires a lot of time to be invested in. And one more important point that I would like to stress upon here is the creating documentations just for the sake of NABH, just for the sake of assessment will not help in the long run. So we need to keep in mind that it's been created to establish a good process. It has to be followed accordingly. So these are 5 fundamental steps stated by a Canada-based company called Montreal, and they have clearly illustrated all these 5 steps of how to create an SOP, how it is benefited. So I have shared a couple of links which everyone can access it. So how to start and where to start. So this is probably the most technical and difficult part of where do we exactly begin with. So from an NABH perspective, we can decide on the type of SOP first. So this is decided based on multiple factors like the number of employees, the number of departments you have, the scope of services, etc. So based on that, either it can be a single document with all the SOPs in place, or we can create chapter-wise SOPs. And if you're a little bigger hospital, and if you feel you need department-wise protocols, then you can go for department-wise SOPs. Or even more detailed, if you require, then you can go for individual or process SOPs. So this will ideally be the first step before you get into the actual process of creating an SOP. So for a big hospital, which provides complete ophthalmic services, there will be somewhere around 30 manuals, which includes both clinical and non-clinical departments. So this is a list of manuals which we have here at Arvind Eye Hospital, Coimbatore, which is a big hospital. Whereas for a small hospital, which predominantly focuses mostly on general ophthalmology and cataract, for example, there will be around 11 manuals. So that is 10 chapter-wise manuals and 1 Apex manual. So this is the list of manuals which we have for our secondary center based in Udumalpet, which focus more on general ophthalmology and cataract. So deciding on this will be the actual first step and an important step. Then after that, how do you go about? So you have to look for the requirement. So we are lucky that NABH has clearly given us the objective elements that they require documentation for. So we have to focus on them, and we have to eliminate all the objective elements which is not applicable to us and filter to what is applicable. And based on that, we start creating the SOPs. Then another good idea will be to look for sample SOPs from different sources. So NABH itself in its website has a chapter-wise manuals of a Coimbatore-based hospital, which is an excellent resource, which will help anyone to understand how it should be written. Then all the best practices and innovations which we do in a hospital can also be part of the SOP. So they should also be put in whichever matches the objective elements. Then putting it to use. So after creating the SOP, it should be put it to use rightly. So there's no point in creating a wonderful SOP and having kept it at the central office. So it should actually reach the intended users. It should be accessible by them, and it should be understandable by the intended users. So this is the key. If this is not done, then it is as good as not having an SOP. So who should write an SOP? Ideally, a member of the quality team, a quality manager or coordinator. But in hospitals where there is no separate quality department, it could be the hospital administrator or the hospital in charge. But basically, there should be a person who has a thorough understanding of the entire hospital process, so that they'll be able to relate with the objective elements and create a process which doesn't compromise the actual requirement. And they should also have basic knowledge about the structure, numbering, how to capture the relevant content, and also the ability to present in a simple and understandable manner. Team involvement. This is very, very important because different chapters has different type of people involved. So you have to identify the team among them. You have to discuss with them the objective elements. How are they going to implement based on the requirement? And after getting clarity and consensus, finally we come up with the protocols which goes into the actual SOP. So contents of a good SOP. Ideally, a good SOP should have the prepared by, reviewed by, approved by name. So these are the authors. So this gives the authenticity and the value it actually deserves. And any document to be considered official, it should have a SOP number, it should have a documentation number. Then the points should be clearly written in bulleted points. So there's no necessity at all to go for big sentences or big paragraphs. It's clearly written bulleted points is more than sufficient, and they should be appropriately numbered. So we should use numbering for all the heading, subheadings. It will be even good to avoid bulleted symbols. And the language should be simple, understandable. It not be hi-fi English or classy English. Simple, good language, which is understandable by all, is the key. Then wherever possible, we can also use flowcharts and pictures. So this is the first page of one example, first page of an SOP, which I would like to share an example, which we have here. So the header common across all the SOPs, and also the document name, and the box which follows the details of the authors. And that details of the authors is where we get the signature of the authorized persons. That signature gets the validity. So this is the common page. Likewise, we should define this page right at the beginning. All the pages should be in similar nature. And how do we write? So I would like to share a couple of examples here. So in simple terms, what we write should be practiced, and what we practice should be written. So there's an objective element like sound alike and look alike medications are stored separately. So for this, you create an SOP stating how is the list prepared, who approves the sound alike medicines, what color coding you're going to follow, and how it is going to be arranged. So based on the written protocols, you do the implementation. So all the three should correlate. So this is how you go about creating SOPs and implementing them. And wherever possible, as I already said, it can also be depicted in the form of flowcharts for easy understanding. So this can also be considered. So how does an SOP help? So at the end of the day, what SOPs bring is the most important concept of standardization. So it becomes uniformity, consistency, which in turn leads to efficiency and gets the desired results. And also it ensures deviations are managed accordingly, because with the proper written protocol, you don't know whether you're deviating from the actual process or not. And it also minimizes the misconception about how a particular process has to be done or how it should not be done. So overall, it gives clarity and helps us to perform efficiently. The implementation. So key is training. So whenever we bring in a new protocol and document it, we have to make sure training is given to everybody, right from first level to down the line. everybody should know. Only then everybody will implement exactly what is required. So it has to be intense training followed by intense supervision at the initial stages before things become routine. So my take-home message is SOPs are a definite key to success. Without any doubt, they act as a strong source of guidebook. And the important point, again, which I would like to stress here is they need not be huge documents with hundreds and hundreds of pages. It should be a ready reckoner. It should be relevant. That is more important. And they should not be prepared just for the sake of NABH. If it's done so, then apart from 2 or 3 people in the organization, nobody will know what is actually the protocol in place. And ultimately, good SOPs are the foundations which leads to good implementation. So, thank you.
Thank you, Mr. Gautam Kumar. That was a wonderful presentation. And I hope everybody knows what is SOP is. See, when we started off at Muthoot, there were agencies coming up and telling me that, you pay this amount of money, we'll give you the SOP, we'll write it for you, and everything will be taken care of. But I went a little differently. I said, all the departments, we had about 16 disciplines there. It's a multi-specialty hospital. So I asked all the department staff to write their own SOPs. And they said, sir, it is a little difficult. I said, what do you do when you report at 8 a.m. until 5 p.m. when you go off? You write it in your own language. Ours is Malayalam. You write it in Malayalam by bullet points. And then we involve the quality manager and then the expert team to sort of translate it and then compile it into an SOP of that particular department. Now, when SOPs are, beginning of refining yourself. As he said, you will realize what is the gap and then you compare it against with the standards given by NABH or other standards and then try to close the gap. I think, and then one more thing about SOP is we have attrition rates in every department, nurses side or doctor's side. And once you have a SOP in a particular department, you have a copy in that particular department. Any person who is joining the department is asked to read that SOP first and orient themselves to what exactly is our standards of that particular institution as accredited by the NABH and what is expected of him. He may be coming from some other institution, but he should be aware of what exactly written in black and white for our institution. So thank you very much. I think if there is any questions to Mr. Gautam Kumar, you can go ahead. Otherwise, please go ahead with the next presentation. Thank you.
Thank you, sir.
Thank you very much, sir. Thank you very much, sir. Now I request Dr. R.D. Ravindran, sir, to give his comments on the first two topics, sir.
Chandrasekhar.
Yes.
I mean, at the outset, I'd like to wish a happy Onam to everybody, and also thanks for this opportunity to be with all of you. I mean, in the early remarks, Dr. Meena mentioned about the Clinical Establishment Act and the need for having NABH accreditation. It's very important because now if you have NABH, even at the entry level, it will address all the statutory requirement and also the regulatory requirements. Whatever is needed, it is all there. The point also made by Dr. Sunita, it's once you have all that, even when you have some kind of a medico-legal implications in your practice, this will be able to put you on a very strong footing. The other important thing about having accreditation, even at the entry level, is that it is easy for the staff to understand the whole process of quality because it gives a framework and they are able to understand that. So without that, we may be able to talk about that. We can put in place a process and written down protocol, but it doesn't really, without that framework, people may not be able to really understand that part. So in that way, and doing this NABH based on the standards, you are also able to understand the gaps which are there. And it's a really stepping stone, as Dr. Sunita mentioned. And other interesting thing is instead of kind of centralized and top-down approach, you are able to delegate it to the next level staff. You are able to really empower the staff. And when there is an external scrutinization, everybody comes together, actually. I mean, it's not, it's the interest of the leader who's pushing it, but everybody wants to show that their department works well. In many of those things, it really helps. And when you have that, something like NABH accreditation, you maintain certain records, all the documentation as mentioned by Gautam, it is all there. It's not about, it's not anymore kind of oral communication, it's all written down, and you have got certain objectives which are measured. And you also understand when you have to redo the training and all that. In many ways, having this even entry level accreditation really helps, even financially, because it's also becoming a requirement for the insurance. So in that way, but I would like to say that the spirit of doing that is very important. It's not about getting the certificate, but doing it with the real spirit that you want to bring that element of quality. You want to make sure that all your staff understand that. Only then, as Mr. Dr. Mohan pointed out, I think it has to come from the staff. And what we really do on a day-to-day basis, what should reflect on our manuals and then the SOPs. It should not be something different. Something is there in the manual and we do something different. It will never go. Yeah. Thanks, Chandrasekhar. Yeah.
Thank you very much, sir. Now, I would like to request Dr. Kumaran Murugesan to talk about another couple of topics which are quite important. One is the committees, the other one is the code drills. He is an alumni of Aravindaya Hospital, Madurai. He is graduated from MGR Medical University and Royal College of Ophthalmologists in 2003 and 4. He is a specialist in comprehensive ophthalmology with interests in refractive surgery and medical retina. He has been part of NABH training programs, particularly with respect to HIC and operation theatre techniques. He is the Chief Ophthalmic Surgeon at Kumaran Eye Specialty. Over to you, Dr. Kumaran.
Good morning and a warm welcome to all. Dr. Chandrasekhar, thank you for the introduction. At the outset, I'd like to thank Kerala Ophthalmic Society, Dr. Meena, Dr. Raj for this opportunity, and I would also like to thank Dr. Nirmal, Chandrasekhar and Gagan for helping me with this presentation. My topic is on committees, code drills and training. Yeah, so what is the basic definition of a committee is that a group of people come together for a common cause, and in a hospital setting, this is to ensure that the hospital undertakes all its work process in a smooth, seamless way to deliver a high quality eye care to all. So basically, the committees can be grouped into medical, HR related, administrative and financial. I do understand that in a smaller eye care setup where they function with a single proprietorship and a couple of medical and paramedical staff, it does not make sense to have all the committees in place. But however, in a larger organization where you have multiple departments, the presence of all these committees could be very helpful to provide a seamless workflow. So what is the objective of a committee? A committee should function under all these proper headings. They should have an objective. The function should be well defined. The members should be defined, which could be either from 6 or 13 members. However, in a smaller organization, it could be even 2 or 3 members, depending upon the volume of the organization. The frequency of the meeting should be defined. The quorum is very essential because a minimum of 1/3 of the members or 3 or whichever are greater should be present for the meeting to go forward. The meeting venue should be decided, and the minutes of the meeting should be circulated to everybody. The reporting authority and every committee has to be evaluated to see its presence and whether it is being working properly. All said and done, the common joke which is going around is that if you want to kill an idea, always have a committee. Negative things also do happen in a committee when one committee member or the boss has become very bossy, or there's an interpersonal relationship problems with the committees. But what's said and done, that the presence of a committee always would be very helpful so that multiple ideas come in and you can approach a particular problem in a more organized way. So I have put forward all the committees that could be possible in a healthcare setting. Yes, this is not needed for a smaller organization. The one that is listed on the left are all medical related committees, and on the right are administrative committees. It is beyond the scope of this talk to look into all these committees, but I'm going to look only into the mandatory that is required for however small or big organization may be. To start with, the Medical Executive Committee looks into all the recommendations of the other committee, staff recruitment, making sure that the proper allocation of work to all the medical staff is taken care of. The Bioethics Committee, however, is a very good and larger organization. It actually acts as an advocate between the patient and the medical staff, and also looks into the research activities as laid down by the ICMR. This is one of the most important and the mandatory committees required in any organization, however small or it may be. It looks into all the policies and procedures relating to pharmacy services, formulates a drug formulary, looks into the adverse drug reactions, and more importantly, also looks into the policies on the use of narcotic and psychotropic drugs. The Hospital Infection Committee is another mandatory committee which looks into the prevention of healthcare services in the organization, forms of effective antimicrobial program, looks into the immunization schedule for the staff, and also biomedical management. The Safety Committee looks into the safety and the employee health, looks into the facility inspection rounds and segregates all the hazardous substances, and in the case of any undue event, looks into the failures and tries to prevent them from happening in the future scenarios. The Biomedical Waste Management Committee is very crucial. It's one of the legal requirements, because this is one law where the Pollution Control Board can really shut down your hospital before an investigation is even initiated. So every healthcare organization has to look into this committee very seriously, which looks into the segregation of waste, collection of waste, transportation, until it leaves your hospital till it reaches the area of final disposal. The Code Blue or the CPR committee looks into all the Code Blue activities, make sure that the equipments are present to all the staff, and frequently updates them. The Internal Complaint Committee is gaining importance after the Me Too campaign. Any hospital or any healthcare organization which has a lot of female staff has to provide with this committee to ensure that the healthcare organization is a safe place for all women workers. The Employee Grievance Committee looks into the grievance between the employee and the employer and tries to settle them at the earliest. The Audit Committee basically looks whether the treatment given to the patients has a clinical background and scientific based or evidence based treatment is given. You do not stand a case if your medical records are not perfect in the case of a legal intervention. So ensure that your medical records are done properly, and a push towards electronic medical record system is the duty of the Medical Records Committee. So with this, we go into the next part of our talk about the codes. There are multiple codes available, and it is good that everyone knows about these codes, but I'm going to look only to the three main mandatory codes that are required for an organization to look into is the Code Blue, Code Red, and the Code Pink. The Code Red actually different organizations look at Code Red differently. The Code Red in the IT sector means it is a virus, and is the name of the first virus which was infecting the computers was Code Red. But however, in the healthcare organization, Code Red means fire safety, and it basically teaches the fire safety protocols to all the healthcare employees. This is a simple chart which I took from the NABH website, which clearly defines the healthcare organization based on the infrastructure and what are the fire safety requirements that is needed. Of course, the fire extinguisher being the basic requirement for any firefighting tool. Apart from this, an healthcare organization also needs to know about the other safety equipments like the hose reel, dry riser, wet riser, downcomer system. It takes a lot of time to understand what all these things mean, but it is very important to implement them depending upon your fire safety engineer. The presence of a basement in a hospital needs special attention, as you need to install a sprinkler system based on this. You can just refer to the NABH website for the minimums of fire safety equipments where you can get this. And it is a mandatory requirement that all hospitals obtain a no objection certificate even before they occupy the premises. And due to some due to unavoidable circumstances, when you're not able to get a no objection certificate, a third-party NOC is also acceptable as far as the entry level is concerned. So the main objective of the Code Red is to educate the staff about the fire drills and the presence and the absence of a fire suppression system, educate them about all the other activities as far as the Code Red is concerned. Fire drills are mandatory, should be done every year in non-patient areas and quarterly in patient areas. The main thing is that it should be done in an unannounced manner. Remembering the RAISE acronym is very important, which means Rescue, Alarm, Contain, and and extinguish. R means a rescue in the event of an immediate danger. Rescue all the vulnerable patient first, which includes the non-ambulatory patients, the wheelchair patients, infants, and then the ambulatory patients. And every staff should know the mechanism in which the code red should be activated depending upon the protocol which is followed by the hospital. If you're able to contain the fire, it is very good. But in case you are not able to contain the fire, you try to extinguish them and follow the acronym of PASS, which means pull the pin of the extinguisher, aim the nozzle at the base of the fire, squeeze and sweep. In case you are not able to extinguish, evacuate the place at the earliest. So the location of all the fire safety extinguishers is mandatory, and every floor of the hospital or every department should have the separate fire safety plan installed at the entry, which could be easy, and the staff should be aware of the exit points. Always remember to use the cone or the pink cone during your fire drills. This is basically will not panic all the bystanders who do not know what is happening here. So code blue is basically to prevent any medical emergencies in a patient. Anyone can activate the code blue, starting from patients to visitors, and they provide basic BLS support till the support team arrives. It can be activated by pressing a code blue button, which will be present in all patient care areas. And every member of the BLS team should know what they are doing, and they should act in a time-bound manner, not to forget that the communication to the patient attenders and briefing them on what is to be done. It is always good that all the staff in the hospital have at least a basic BLS training, including your security and housekeeping staff. Having a couple of staff with the ALS support is always helpful. The basic principle is that you have to make sure the vitals of the patient are stabilized before the team arrives. This is a flow chart which tells you the responsibilities of each member in the staff. The CPR committee looks into all the equipments needed to carry out a code blue, maintain an emergency a drug list, check them on a daily basis, and look for their expiry. Code blue training is very important. It should be documented through video as well as through hard copy. There are a lot of agencies which provide BLS support. Don't forget your new staff when they come in. Without basic life support training, do not put in your staff inside the duty. It's always good to have a MOU with an ambulance and make sure the ambulance arrives. Have a code drill for this too. So every code blue event should have a record like this, and you should also have a drill for the code blue activity. Code blue is basically for infant and child abduction. Try to prevent them by tagging the parent and the child at the entry. On activation, close all the exits, alert the securities, and initiate the search. And follow up with the CCTV footage. In case you're not able to trace the child, then you inform the police. Thank you.
Now I request Dr. Sashikumar sir to give us valuable comments, please. Sir, you have to unmute, sir. Dr. Sashikumar sir.
Okay. Yeah, that was a very good exhaustive talk in a small time by Dr. Kumaran. See the importance of these committees. He has emphasized the importance of committees, but in a small hospital, at least a few committees like Hospital Infection Control Committee, then this Code Blue Management Committee and Biomedical Waste Committee, Management Committee, all these committees are very important. And one thing that you've mentioned is the involvement of the staff in all these committees. Actually, it makes them more responsible, and you're actually empowering them so that they will feel that they will have a sense of ownership in the management of patients in the hospital. So they will no longer start doing their work, they will start enjoying their work. That is very important. And this fire NOC, say some of the states, they insist on, actually I think the national building rules insist on fire NOC even if you have only 1 or 2 floors in the building. But some of the states, they don't insist on that. So that is a clash of interests, I mean clash of this thing in the NABH accreditation. But for entry level, that is not a must. That is what I feel. Training is very important. The training is not just a one-time training. It should be an ongoing training, because the more number of staff that you come, and the staff, their educational background also is different. So you'll have to continue training the staff at all levels. Thank you very much, Dr. Kumaran, for that wonderful talk.
Thank you, sir.
Thank you very much, sir. So next talk would be given by Dr. Gagan Dudeja. He is at Narayana Nethralaya and with a lot of experience. He is a principal assessor, and he was also part of the team which formulated the eye care guidelines. He has done his master's from Gwalior Medical College. He undergone long-term fellowship in orbit oculoplasty and ocular oncology at Arvind Madurai, and he has trained in ocular oncology from MD Anderson Cancer Center at Houston, Texas. Over to you, Dr. Gagan Dudeja. He'll be talking about KPIs and self-assessment. Thank you.
Good morning, everyone. Thank you, Dr. Chandrasekhar. Thank you, KSOS, for this opportunity. Happy Onam to everyone. Give me a minute to share my screen.
Again, your voice is breaking.
Okay, just a sec. One sec. Zoom is just giving me some. It.
Yes, your slides are seen, Dr. Gagan.
It took me a while. Okay, so can you hear me now clearly? Fine. So the first thing I would be talking to you is internal assessment. Dr. Sunita started with gap analysis. Dr. Chandrasekhar discussed, we had all the discussion by Kumran. So if you realize all those things we're talking about, checking certain parameters, so they all form part of internal assessment. How do you do a gap analysis? You do an assessment and find the gap. So that's what I'm going to talk about, and how we can do and what does it mean. So what is an assessment? So the keywords here are: an assessment has to be conducted in a systematic manner, independent, and there has to be a documentation, as told before. If it's documented, we know how it was done and what was the thing which was found. And an assessment has to be done against the established criteria. So let me say I'm going to assess something. Let's say I'm going to assess a coffee shop. Then one of the criteria there is to see what is the temperature at which coffee is being served. That's what they do in coffee day. They check the temperature of machine. So you pour a cup of coffee and see that the temperature is within 50 to 60 degrees or whatever is the parameter. So you have a parameter against which you assess the outcome or assess the process, what you see. Now, for purpose of NABH, we need to understand these three words: internal assessment and external assessment. Very clear. Internal, something which you do on your own. External, when someone from outside is doing it for you. Same thing like our internal practice exams and an external board exam. So something is internal, something is external. Now, internal assessments are also called as first party assessment because you do it yourself. It does not mean that the people who are in hospital. You may also invite certain outsiders, but the onus or the entire process is being driven by you. You are the owner of the process. In an external assessment, normally like an NABH assessment is a third party assessment because there is no relation. It's an independent organization and having no relation with you. And then there is something called second party assessment, means it's typical in industry. You have a vendor. So someone is supplying something to you, and let's say the car manufacturer audits the tire supplier agency. That's a second party where there's still a related transaction. So for purpose of NABH, we are always going to stick to the first party and the third party. So why do we need internal assessment? It is a requirement for accreditation criteria as per NABH. It's more important. We also want to discover weaknesses in our system before they are detected by external assessors. So you really want to see how well you are prepared and where do you stand. Internal assessments are also a management tool to improve. So you really know where you stand and how you are going further and how are you improving. They also serve as a tool to verify the corrective actions. There was some deficiency, it was found corrected, but in long term, what's happening? All these things come up through internal assessment. So the important thing with internal assessments are a predetermined schedule. Typically, you follow a quarterly schedule for a full assessment. Entry level, you can do a 6-monthly schedule. 1 yearly becomes too far apart to be really helping you in any kind of improvement. Now you can say who decides this thing. It's your prerogative. You can even have a very overzealous quality person wanted to improve his hospital by having a monthly internal assessment. Can be done, but the issue there is that every assessment is a cycle. So if you do an internal assessment, you are going to find some deficiencies. You need to take some corrective action. That's going to take some time. Typically, you might need 15-20 days or a month to set right the deficiency which you have found. And by the time you have another assessment, the first entries are still open. So a reasonable amount of time, typically 3 months is what really fits into very, very multiple criteria. That's what everyone would be following. They also should comply with your own quality system. NABH is add-on. It's not saying that you can't pursue quality beyond NABH. You can exceed NABH standard. You can also be having certain other quality systems. So you have to take all those requirements when you are doing an internal assessment. It can't be just focused on to, let's say, NABH entry level standards alone. You have to have trained and qualified personnel who know how to audit. How you do that is you take your staff and they get trained for it. So, or you may be even having, external quality managers and quality staff helping you out depending upon the scope of organization. Small organization, better train ourselves. So we can train ourselves, we can train our staff. And as we progress along, all of us improve. It will take a couple of internal audits for us to become good auditors. The most important thing for internal audit is independence. So, it can't be that you are my friend, you can't really pinpoint things in my department and I'll not do, you scratch my back, I'll scratch yours. So if you really want to have anything, it has to be ruthless, independent exercise. I get assessed, I also assess. Both ways, it has to be independent and no one has to really feel bad about it. Most important to maintain the assessment records that help us going back and finding out things. It's also good for external assessors when they come to see how organization is working. And all these records, once you do, like when you write an non-conformance or you find a deficiency, the first step is you tell what is the deficiency, against what element is a deficiency. So let's say lookalike, sound-alike drugs were not labeled and stored separately. So that's a deficiency. There will be a standard and element along with it. And then you give it to the person responsible. He says that, okay, following corrective action has been done, that deficiency has been taken care of. And the assessor then goes back and verifies that this has been done. So this whole thing has to be documented. So this one, what is the main objective for organization would be to improve themselves, and also very importantly in the topic what we're discussing, for third party registration requirement, that would be NABH. So who's responsible for NABH? Typically you will have to assign one person, an accreditation coordinator, quality manager could be a person responsible in your organization. He or she has to plan the assessment, has to record the assessment, and also involve other internal assessors to complete the assessment. So typically for our hospital, we divide like 10 people do an internal audit. We have 20 trained internal auditors. In our smaller branch, we do it with 5. If it's a really smaller branch, 3. But definitely 3 or 4 people are required for anything to be meaningful, because someone will be busy, someone will be on leave. So, we don't want to have more people to be taking part in this exercise. So this is the assessment cycle. 4 phases: you plan and prepare. You prepare a schedule, you plan when you are going to do. Then would be the conduction of the assessment. Then you record and note down each and everything. And then there is a follow-up for correction and corrective actions. The assessment cycle is complete when you find a deficiency and you go back and close that same deficiency by the person who found it or by someone else who has been deputed for that. So very important thing would be, how do you do assessments? We use various techniques. Interview for certain standard element. There is a question of, we interview the patient, we interview the staff to figure out what's happening. We also observe things. So the assessor will come to your organization, will see how your OTs are running, how your OPDs are running. Just by being by being there and not doing anything, we observe and figure out whether the processes are in place or not. For certain elements and certain standards, we are going to review the documentation. Also examine the patient medical record, reports, minutes of meeting, etc. And conduct mock drills, what Dr. Kumran told. So in an assessment, we conduct a mock code red, mock code blue. All those drinks are there. So make a assessment easy. Sometimes you may like to start by making some checklists. So use of checklist make assessment easy. You don't miss out on points, but then it also starts becoming very subjective, may need periodic revision. So checklist is important to start on an assessment, and please make sure that you keep revising checklist as you progress. So there are 2 types of assessment: horizontal assessment and vertical assessment. Very important to understand this, and a combined approach. In horizontal assessment, you assess one system across several functional groups in the organization. So let's say you are tracking emergency medication. So you're going to check the storage and use of emergency medications all across the hospital, wherever it's applicable. OT, your emergency room, your OPD rooms, your wards, your multiple wards and everything. So you're taking one parameter, checking it across. It's a horizontal assessment. Initially, when you start taking the process, started the process of NABH, all of us going for horizontal assessment because it really makes sure that one particular thing is established across the organization. Later on, when we become experienced, so this is something like you can examine hospital infection control activity all across the departments, all departments wherever it's applicable, or you can examine care of patients all across the department. So one function, one element all across. In a vertical assessment, you look at one particular area. So let's say in operation theater or in an emergency ward, you look for all the elements and all the things which should be applicable there. So you're looking at one unit with all the relevant standards and elements. So this will come with the experience. So once you do your horizontal assessments, you will also learn to do a vertical assessment. Typically, once you are experienced, we end up doing a combined approach. So as an NABH assessor, when we are there, we are doing a vertical assessment with a part of horizontal mixed into it. So how do you know that your internal audit is helping you? A reduction in number of non-conformances over a period of time. So first audit, you have 200 non-conformances. Second audit, you have 150. Then you have 100. Then you have 50. Some non-conformances will be always there. So a reduction in number is always a good sign. Then what you are identifying in your organization, the same kind of non-conformances are recognized by the external assessors. Means you are on the same page. What is our weakness is also being picked by others. It should not happen that we say we are conforming to standard, but the assessors come and say, no, it's not a confirmation. That means either we have wrongly implemented the standard or have not understood the standard. So that would be about the internal assessment. And there was one small key thing for my talk was regarding the self-assessment toolkit. So when you do your internal assessment, you use the same information to fill in a self-assessment toolkit, which is downloadable from NABH. So it's an Excel sheet where you have all the standards and all the elements, and there you can say what is the evidence and how is the conformance, non-conformance, partial conformance, or a complete conformance. All these things can be taken from your internal audit. So a compilation of internal audit will give you the internal assessment sheet. Okay. So next would be the key performance indicator. I will start this one by deviating from our medical science, and let's understand what a key performance indicator is. Key performance indicator is a measurable parameter of a key function or an output of a process, right? So whatever is very, very important, but has to be there, and it is measurable. It is not qualitative. It's not like good, better, best. So it has to be measured. So just to go with airlines, and Indigo always puts this thing, best on-time performance. Because if you're looking at airlines, there are multiple parameters you want, but one of the two key parameters, what you would be looking at airlines would be the safety and on-time performance. You may be, you may crib about a little bad quality food, but always, tolerate that. So what Indigo does is Indigo says we are best amongst all. How? Because they get data from DGCA. DGCA records data of all airlines, how much time percentage were there. So Indigo says I'm 99, others says 97, others says 95. Now with this kind of data, there's always some kind of a acceptable cutoff point. So that depends upon what industry it is. Like for cataract surgery, we have a cutoff point for 6/6 vision, 6/12 vision, WHO standard for successful cataract surgery. So similarly, let's say for an airline, the cutoff standard is 95. So all of us know that 95 is an acceptable benchmark. I would try to take my organization further than that. So instead of 95, I want 96, 97, 98. So first, right now I'm at 80. So I'll try to improve myself and put my benchmark at 90, then 95. Then I start exceeding the benchmark. So similarly, Airtel and Jio, we were discussing about our data when we were having a this talk. So Airtel says it's faster, Jio says it's good. But how? They did a speed test and then they quote certain external third party saying that we are faster, and they're using it to propagate and advertise also on that. So yes, we are fastest compared to our competitor based on this parameter. So it's the only parameter. But this is a key parameter for customers that, okay, I need a better speed at a price what I'm paying. So that would be the definition of KPI. Just we'll leave it on for a few seconds for you to read. And KPI is not really medical. It can be everywhere. You may also use the word performance indicator. Sometimes you can use other synonyms. Okay, so now we are coming to healthcare. Now, without coming to clinical, in healthcare, we are all used to clinical audits, surgical audits. We have our complications. So those are kind of KPIs. We see how many patients improved after cataract surgery, what was our complication rate, how many end-offs we had. Those are all kind of key performance indicators. But to understand, go beyond. There are also managerial indicators. There are also non-surgical key performance indicators. So something like patient wait time. You can calculate how much patients are waiting in your organization and what is the time which you want to benchmark it to. What is the time you want your patients to be turned around. then how many patients are utilizing your facility. So, your waiting halls and waiting rooms, how they have to be arranged, that, if there are lots of patients in your place and the waiting halls and waiting rooms are becoming inadequate, you have to see whether you want to distribute them or you want to expand your facilities. But to do all these things, we need to have data at hand to take certain decisions. Very important. Lots of complaints everyone would have regarding insurance payments. But have you calculated what is the insurance claim processing time or cost? So a particular insurance company is really delaying your claims. The other ones are good. How do you know which is good or bad? So you might like to look into these kind of KPIs also, which are really financial and actually help you much more, rather than even talking about that, okay, we are doing it for sake of NABH. So if you do have some kind of a process of taking KPIs of your insurance and cashless things, you'll be really surprised how much money you can save. Then patient care, medication errors. Very important to have. Ophthalmic, we really think it's topical drops, not so much, but medication errors we don't give too much of emphasis, but it's really required. Then for your staff planning, you may have some kind of patient staff ratio KPIs, indicate how you are going forward. So when you are trying to do KPI for entry level, the onus is onto you. So as you realize that there are 10 chapters, managerial chapters and clinical chapters, you can take KPIs from both areas. So you can have a couple of 2-3 managerial KPIs, 2-3 clinical KPIs. You can even exceed those KPIs. You can start small and then keep on adding to it. If you're going in for eco or a full standard, there are certain mandatory KPIs which NABH has stated, and others are by your choice. So first you want to say KPI, you have to define what KPI you are going to select, plan how you're going to collect data, who's going to collect data, make sure that you are using the right formula to arrive at the correct value. Once you have that, you need to set a target value for your KPI. That will be benchmarked to some kind of a national or international guideline. You analyze your data and understand where you stand. You may be exceeding target, very good. You kind of plan and you change your target value and try to even exceed that. You are much beyond, much less than the target value. So first thing is you plan your actions, see where you are going wrong, take some corrective actions and try to attain your target value. It may be okay. You may attain your target value after a couple of months or maybe in a year, but we know where we are. We have to be on path of self-improvement. So this is a patient-centric indication. Time taken for initial assessment for outpatient and emergency, that is by NABH. So we have defined for ICANN 90 minutes to be the time. So you have to have people who have been seen within 90 minutes divided by the total number of patients into 100. So you may have seen 100 patients, all 100 have been seen in less than 90 minutes. You have seen all 100 patients within the time defined. You have seen 90, you get 90%. So you can have a target value and you make sure that you really almost all the targets are above 90%, if I may say so. Then some kind of an outcome indicator. This would be a surgical outcome indicator. What will be the infectious endophthalmitis after intraocular surgery? All of us do that. You already have this data and we really know how to calculate that because that's a job of first year PG, if I'm not wrong. At least that's what in our medical training. Rate of complication, so posterior capsule rupture or some complications. And then there are some other sample indicators. You can just take a minute to read them. All these things are up to you. You can select any of these. Now, before you wonder that from where we can get all these indicators and formula, I can tell you where to find that would be the AIOS CME series on NABH written by Dr. Nirmal. All these indicators, whatever I put on this presentation and the formulas for calculating them are in that book, which you can download from AIOS website. If not, someone can really share with you the WhatsApp group or your KSOS group. And other place where you are going to get mandatory KPIs is in the NABH standard book. So whichever standards you pick, whether it's eco or small healthcare or something, you will get the KPIs mentioned in the NABH book itself. So certain more outcome indicators for different surgeries. So depending upon your scope, if you have got cataract, retina, plasty, you can have different departments can have their different KPIs. So every department can start with 1 or 2 KPIs for the most common surgeries and go and improve. But this is not the only indicator because everyone starts with clinical indicator because that's our core competency. You also have to include your other indicators and especially going for financial and certain indicators which take into account your stocking and your stores and purchases, and you will definitely save money. Even you will save money if you have your own pharmacy and you would like to have some kind of quality indicators built in, and particularly also for your optical dispensing, because that's one area which generates income, but there's quite a significant wastage also there. So let me see if I can pull out some spectacle related indicators. So you can see there how many wrong refractions are happening, how many spectacles, because typically if you have a wrong refraction, we change the spectacle, but somewhere we are bearing that loss. How many long transcriptions of prescriptions are there when we have written wrong or optometrists have written wrong? How many times the wrong glasses are being made, wrong contact lenses, and then definitely patient satisfaction. It's a cutthroat business, money earning business, so you like to have something. So spectacles is a very area where you start putting in some kind of KPIs, you really save money and you really improve quality of your service. And similarly with iBank indicators, all of us do that. So if you really see, we do have this data, but our purpose till now is we collect this data and just keep them in percentages. We really don't use this data. The purpose of KPI is to use that data for our improvement, to save money, to improve our services. That is where we have to go. Data collection and getting these percentages is not a difficult thing. All of us will be doing something or the other. How you are going to use it for a betterment is where things are. And if you open up eco chapters, there is a chapter CQI. The standard number 3 deals with mandatory KPI, which I have not put here. You can actually check in the book. Thank you for your patient listening.
I request Dr. Kamala to give her comments on this topic, please.
Yeah, Dr. Gagan, am I audible?
Yes, madam.
Yeah. So Dr. Gagan did a great, very exhaustive list of the KPIs. So what I would like to say is KPIs basically work on the foundation that what gets measured gets done. So basically that is the thing on which the KPIs work. So it is very good to have a good amount of KPIs. But when we go for assessment, what we see is there's huge list of KPIs, and most of them are just there because probably it has been told by some consultant, or it has been done in some other hospital and they did not get an NC for that. So because of that, that particular KPI will be seen in that list. So what the hospitals have to take care is that they have to form KPIs which can track their own efficiency, effectiveness, the quality, timeliness, the governance of the hospital, compliance of the to various SOPs, the behaviors, the economics, as Dr. Gagan said, the performance of certain projects. Many of us are into a lot of projects, so performance of projects and personal performance. Of course, the HR audits, the HR KPIs, again, they are very, very important. And not to forget the resource utilization, how we are using the resources. So these are also have to be, comprehensively evaluated and very correctly told by Dr. Gagan, not in percentages alone, but we have to see where we are heading towards with all the numbers and the figures what we are getting at the end of the month or whenever you're evaluating your KPIs. Thank you.
Thank you, Dr. Kamla, for re-emphasizing what is the gist of the talk. Only one more addition. Please don't get scared by the list. All of them are not required. So you have to really start small. For entry level, as discussed earlier, you can start with 5-6 KPIs. This list is 60-70. Please go as per what your requirement is. Don't get scared by the list.
Yes, so the basic crux here is you need to get some, modifiable data out of the KPIs, what you are evaluating. You need not have 100 KPIs and don't get anything out of it. You may have 10 KPIs and improve on a whole lot of them. So that is basically the crux of the whole thing.
I would like to make is, it will be good to have some cost related KPIs as well. Looking at the procedure cost, how much you have spent for a particular procedure, a particular month. That will also help you to understand the variation in the process and the protocols in place. Sometimes it also helps. Very often we don't look at the cost part of it. Looking at the cost, it also will help to understand the variation in the practices, especially if you have multiple hospitals, multiple operating rooms, multiple surgical teams. Then there's one way also to look at the practices.
Shekhar, are you there?
Yes.
Your talk.
Okay, my slide is visible. This is the first slide. Greetings to all of you, those on Zoom and YouTube, and happy Onam wishes, and thank KSOS profusely for this beautiful program. My talk is the last of the entry-level certification part. It is about HOPE application and assessment. Currently, there are more than 800 plus accredited and certified hospitals empaneled in NABH, of which majority of them are at entry level. Recently, there was a notification saying that there will be desktop assessments, probably a virtual assessment through remote access, or a hybrid assessment. That means there will be some people on the desktop, on the online, and one may be visiting the center. So this is a modification by NABS to ensure the continuation of this accreditation and certification processes. Entry level, we know there are 149 elements for SHCO and 167 elements for an HCO. Now, what is this hope? This is actually a revolution which brought in online work from NABH even before the corona times. It is healthcare organizations' platform for entry-level certification, and it has brought a lot of transparency into the system, especially for entry level. Whatever I'm going to talk is with whatever we have been experiencing. At Aravind Eye Care System, where we have 14 hospitals, we have 9 hospitals with entry-level certification. Personally, myself and Gautam have been involved in 4 of these hospitals in implementing entry-level. I should say, each of the time we learn new things. It is going on changing. So first, it is very important to understand your preparedness for applying. Why? Because previously, before this hope came into existence, we could apply and wait for months or probably a year also to go for the assessment. But now it is not so. It is time bound. Once you go and apply in a hope application, you will have only 3 weeks, 21 days to finish your desktop application process. Otherwise, it will get cancelled. And even the NC closure is all time bound. So these are the 2 standard books for entry level. Below 50 beds is small healthcare and above 50 beds is healthcare organization. We go by these elements as always. But the most important is, this is the guidebook that has been released by NABH, which gives clarity into all these elements. So there will be lesser amount of assessor variations. So whatever element is applicable for you, please go through this guidebook, which will give a better clarity and easier for you to implement and give answers for your non-conformities. This is the self-assessment toolkit which Dr. Sunita and Dr. Gagan have been talking about. This is very important. At the beginning, you do this. Just before applying, you do this. What do? There are 2 aspects to it. One is the documentation process and the other one is implementation. Only if both are say yes, you'll get a 10 score. So without that, you will not be able to go in for an application. The evidences should be mentioned like this. You say yes, and say where is it in your manual? What is the image? So this will give 100% clarity to yourself to make sure you have satisfied that element. When this is done and you are satisfied, especially with respect to the statutory elements, you go ahead and apply. Example would be facility management and safety. It will say facility inspection rounds to ensure safety are conducted periodically. Your facility inspection, if FMS manual in a small hospital will tell how you do it. The safety committee will do it. Rounds will be done once in a quarter or once a month as per need, and it will be predefined. This is the checklist and it is being undertaken. So this is both the evidence as well as the documentation. So this is the evidence that it is done. The AAC 7B will say there is a discharge summary to be given to all the patients leaving the organization. So in the manual on AAC, you will have this clearly defined. Discharge summary is given to all the patients who are admitted. Now, including medical legal cases. This is the evidence that you have everything, all the components of discharge summary in it. So this is, you will be happy to have this and go ahead for that. But in the application, if you see, there are 2 aspects, discharge summary and discharge summary for people who leave against medical advice. So this is also very important. So most of the small hospitals may not have a leaving against medical advice. They may be daycare units. So you take a statement. So in the last 1 year or so, there have been no LAMAs, but you give an evidence saying that you have this kind of discharge summary for LAMA. So this will become an evidence. So that will be acceptable by the assessor. So that is the basis on which you assess yourself and how we go about with HOPE. There are 4 levels. You register in the QCI HOPE site. You fill in the details, most importantly, the number of beds, which will say whether you are an SHCO or an HCO. Then you will get an email with login credentials. You will log in and change your password. So once you go into QCI HOPE in the Google, this is the home page. So there are 2 options, login and register. First, you register yourself and you see the number of sanctioned beds and you give all the details. Once you get the mail, you get your credentials, you go in and log in into your system, and this is what you will see. There are 7 basic standards, basic chapters under which it will come. Under this, you will have many things like that. So filling HOPE application, you have exactly 21 days, and there are 2 aspects. One is desktop filling, where you upload all the documents, evidences, parts of manuals, and images. And the other one is the most important. It is a mobile app. Through the mobile app, it will tell your latitude and longitude, whether you're doing it from the hospital itself. So these images, these evidences will be uploaded on the mobile app. So the whole publication for a healthcare organization will have approximately 215 uploads, and SHCO may have about 180 uploads. Why I say approximate? Because some of the services like GA may not be there. And so definitely we don't have OBG, and most of them may not have pediatric. But still there are certain things which we need to do even if you see a single pediatric patient. SPOC is a single point of contact. That will be the contact person, and the mail will be the whatever mail ID you give. So based on this, we start uploading. Primarily, it will be about the hospital. And there you can see the Clinical Establishment Act also has to be put in. So these are some of the statutory evidences you have to upload. One is the manual, one is through the photograph. Here you can see the Pollution Control Board NOC is uploaded. You can see the date, the time, and the latitude and longitude, which says that you're doing it from your particular place. These are MOUs which need to be attached. We, as an eye care organization, will have MOUs related to imaging, lab services, medical gases, and so on and so on. So these things should be uploaded. They should be uploaded in the proper format in a stamp paper with a signature of both the parties. And it is better to have a license tracker to make sure that none of your licenses or MOUs are out of date. Otherwise, you land up in trouble when there is an assessment. These are images of the generator, UPS line, and the OT we upload. These are actual images that are being uploaded. This is the facility inspection rounds checklist, which has been uploaded. The actual list should be uploaded as per the need. These are some of the statistics: 10 most clinical services, frequent diagnosis, and surgical procedures. When you don't have something like OBG, you have to write in your letterhead or whatever that this is a single specialty eye hospital, no OBG services, and that is good enough. This is another evidence of showing your daycare room checklist. This is another thing. Training record should be in this pattern only, as per the person, how it is done, who is the resource person, the signature. This is the format that has been given by NABH Hope Service. And this is the evidence of different color coding, sound alike, look alike, whatever you do with a list of drugs being done. Medication errors and adverse drug events should be. Once you complete all this within 21 days, the final part would be to make a payment. Once you go into make payment for HCO, it will be about 52,000 and tax, and for a small healthcare organization, it will be about 21,000. Once the payment is done, your application process is complete. Then starts the desktop assessment. There will be a remote assessor who will be going through all the aspects of your desktop uploads. There will be one NC. First cycle of NC will be given, non-conformity. You have exactly 7 days till the midnight of the 7th day. You have time to close these NCs. That is why you have to be very sure most of the things, and especially statutory things, are completed. Again, you can get a second chance. There may be a fewer NCs where there may be smaller problems. And again, you get a 7 days to close this. Once it is done, then your desktop assessment is done. So this is how it will show. On your desktop, you can see that small 5 number is written, that in quality improvement processes, there are 5 NCs in this particular thing. So in the particular element, you can see NC highlighted as yellow. So like this, for this is one example, copy of nursing documentation, medication administration is an NC. So what we do, you go take your EMR or your hard copy file, enter that particular part either in a photocopy or a printout, see that the nursing signature is there and their name is there as per the login, and that will become an evidence to close the NC. This is regarding biomedical waste. There are so many aspects they want in biomedical waste. So this is which I would like to say. Initial days, about 7-8 years back, we used to have an open bin and different colored covers to satisfy the 2016 biomedical rules. Then what happened? They said it should be closed bins. So again, that was cleared. Then what happened? The color of the bin and the color of the bag should be the same. So we did that and even labeled them with the biohazard symbol and put up the poster, and we took the photograph. Now, subsequently, what happened? You must label them and make sure it is that, and the blue boxes was needed instead of the blue boxes, blue plastic lid containing containers. We need to put cardboard boxes for blue color and biohazard symbol. So this is what happened. And they said, you have put only biomedical 2016 rule. You have to modify and make it biomedical waste 2018 amendment. So that will become important. So that I said, this is done. We will not have any more NC. Then what happened? Recently, in a month back, for our own hospital, they said you must have bilingual for even biomedical waste. Yes. And then what happened? We went and did a bilingual poster for biomedical. So many changes are occurring because of the clarity in the explanation to each of the element. So this is with after closing all that, this is what we will have. This is with reference to your application, Aravind Hospital. All your NCs have been replied successfully and it is closed. So desktop assessment will be over within a maximum of 2 months from the start of your application process. Then comes the on-site assessment. Previously, it used to be on-site. Now it will become a virtual assessment. Many hospitals have undergone virtual assessment and some have got the dates also. So we need to call it either way. A virtual assessment, they will be working in a remote place and ask you to go through the entire hospital. They can question anybody, question a patient, ask you for evidences, demo spill management, biomedical waste regarding things, or needle stick. So this will be the page for the assessor. So this is how they will also say the latitude, longitude, and they have about 100 elements to be verified in a small healthcare organization for an assessor. For a SHC, for HCO will be another 20 more elements. So scope of services, they'll upload the photograph there itself. It will all be only online. Everything will be uploaded. This is the calibration data for various equipment. This is, you don't have any kind of high dependency areas like cardiac. So you don't have to have all that. So we need to upload, sign it by the medical officer in charge immediately on that particular day, and they will themselves upload this. So on-site assessment will be done. And then NCs, you can see immediately the next second. As soon as they finish the assessment, you can see all the NCs on your desktop in your particular login. And again, you get 7 days to close the first set of NCs. Second set of NCs, you'll get another 7 days. That is maximum. If you are not able to close it, then the whole application gets cancelled. So this is particular one hospital's example, code pink NC. We always thought a small hospital, no pediatric, no need for code pink. But even if you see one pediatric patient, they can get lost, these children. So you need to have that high risk medication. I will show you some examples. So this is they will ask you to label 2 medicines. So the particular person forgot to write the dosage of the medicine. So it became an NC. So again, you have to reload it, upload it with all the details filled in, and also show the manual where the evidences are clearly written, and this will become a closure. So you write an SOP for code pink management and upload the photographs. So this will become an evidence for the code pink. High risk medication is always very difficult. Whether it's a small hospital or a big hospital, they will have a high risk because you're going to have emergency medication. So this is something, we had a color coding done, red color. The list of high risk medications in the hospital we put up wherever there are high risk medication. Not only this, they must be kept under lock and key. More importantly, whether it is a crash cart or whether it is an emergency tray, wherever these emergency medications are there, the color coding for high risk red color, your look-alike, sound-alike color coding should be done. This makes it perfect. So this is how you close. Once your all these things are closed, corrective action reports submitted by the healthcare have been reviewed and accepted. Once all this is accepted, your whole application assessment process is done. They give a clear-cut assessment summary. The assessor will say about the hospital, what is the manpower, everything, and so on. Once this is done, the certificate committee can either recommend or say not recommended or pending, provided there are some queries from the certification committee. Most of these queries will be regarding the nursing. So you need to give an apt answer why, how many nurses are needed in a daycare. It will not be 1:8. So a clinical establishment says only 1:30 and so on. You give the correct answer for an eye hospital, they will always accept it. And they can go on advisory. So this will be the final dashboard. So in the committee decision, it will say recommended and it is done. Sometimes the committee, supposing the clinical establishment you have applied and waiting for a certificate to come, they will say within 3 months you uploaded. With that, your whole process is over and certification committee will say you're certified. In the NABH site or the QCI site, you can see your name of the hospital that it is certified and the date till which it is certified. Ultimately, this is what we'll get as entry-level certification. So this also makes it possible for us to apply for the silver certification. With entry level, you can go for this Ayushman Bharat PMJ fund, Ayushman Bharat, and that's the silver certification. You don't have to go through the entire process. Only those who do not have NABH will go for bronze certification and they'll have a complete inspection. Those who the accreditation can go for gold certification. So this is one of the biggest advantages under the PMJ Act. Ultimately, I can tell only one thing, You need the entire team to work to make it work. Together, everyone achieves more, and it is easily possible with a time frame. Thank the KSOS President, Secretary, and Dr. Rajiv for the opportunity. Thank you so much.
Chandrasekhar, that was a fantastic presentation. I've never seen such a simple way of hope application dashboard being shown anywhere like this. It makes it very simple. And what is NC and how do we manage? It was very well covered. So we'll move on to the next session, and Dr. Nirmal is going to moderate that session. And Nirmal, I don't think he needs an introduction at all. The word NABH, the ultimate authority is Dr. Nirmal. So he was instrumental in getting the ECO done, Eye Care Organization Standards, and he headed the team which drafted the document for it. And it's the only specialty, ophthalmology, where they have a separate standard, and the credit entirely goes to Dr. Nirmal. And in addition to that, is he a doctor? Yes. Is he a lawyer? Yes. He's got a medical legal degree at present. Is he a businessman? Yes. He's got an MBA. Oh, very good. Everything put together. That is a Nirmal, an encyclopedia. Dr. Nirmal, can you take over the next session? And before you take over the next session, can you comment on the previous session also?
Thank you, Dr. Rajiv. Thank you for the kind words. And I'm still to recover from the goose flesh. I thank Dr. Meena, President of KSOS, Dr. Rajiv, and all the office bearers for this wonderful opportunity. And happy Onam for all the members. Greetings to the eminent panelists and speakers of this well-designed program. I think we are running short of time, and the panelists have already told enough about the first session. They covered the basics very well, particularly the entry-level HOPE-related program, as well as the way to go about this HOPE program, and setting the solid foundation for the second part of our program, that is ECO accreditation, Eye Care Organization accreditation. I think since we are running short of time, can we move on to the first talk? So it's my privilege to and honor to introduce the host herself, Dr. Meena Chakrabarty, President of KSOS. I think she won't need any introduction for this audience. And this session will be covering why ECO accreditation, difference between the entry level and Eye Care Organization, how to go about the medical and clinical audit. These are bit critical aspects of accreditation, and how to prepare for the actual assessment. So these are the 4 topics for this session. So it's my privilege to introduce Dr. Meena Chakrabarty. She did her undergraduation and post-graduation from Trivandrum Medical College, and completed her post-graduation and observership from Arvind Eye Care and various other organizations. Did observership in postage segment in various hospitals of US. She's a winner of Tony Fernandez Best Video Award and many awards to her credit, and recipient of the National Award for Prevention of Blindness. She's authored various chapters in textbooks, and also the recipient of American Academy Achievement Award 2012, and received the Best of Show Video Award at the AAO. So I invite Dr. Meena Chakrabarty to talk on why ECO accreditation. Over to you, Dr. Meena.
Thank you, Dr. Nirmal, for those kind words. I chose this topic putting a little pressure on Rajiv because I wanted to share my personal experience. We are moved to a new organization, a new hospital, and we are in the process of getting accreditation for our center. So these are the personal pains and the difficulties that we are facing till we get accreditation. Why a standalone eye care organization standards are different from that of a small healthcare organization? The ECO standards were launched in September 2016. I'm proud to say that I'm sharing the dais, sharing the platform with people who actually implemented, who gave ideas as to what these eye care organization standards should be. So the NABH standards which were applicable to the small healthcare organization are not definitely applicable to an eye care organization, which is a standalone daycare facility. Because of the specific requirements of compliances, the clinical process, the policy and the procedures are all different. The structure of an eye care organism, starting from the operating theater to the outpatient department, is different. The manpower planning and the equipment that we require are all different. So if you look at the benefits of accreditation, the biggest beneficiary is among all the stakeholders is the patient himself, because getting accredited ensures that the patient receives the highest quality of care and safety. He is serviced and seen by credentialed, licensed medical practitioners who know what they are doing. The right of the patients are respected and protected, and the patient's satisfaction is ensured and regularly evaluated. For the organization per se, it indicates that you have a group of staff who are working with commitment to delivering quality eye care, who are committed to see that the patients who enter the portals of the organization are safe, committed to ensure the best clinical outcomes in terms of the visual recovery. And at the community level, that ECO accreditation gives the organization a boost in terms of the confidence that the community reposes on the organization when they come in for treatment. It is also an opportunity to benchmark the best among the best. In addition to all this, it adds a marketing value to the organization and provides a definite advantage in this competitive healthcare field. In terms of staff, they become a much more satisfied group of workers who are learning continuously, working in a good working environment under enabled management. They become more efficient and competent, and there is an overall personality development. And what is more important, especially in a private eye care center, is that we are able to achieve accountability for the staff. They are accountable for what they do, not only for the medical staff, it's also true in terms of the paramedical staffs. The ECO standards have 66 standards and several objective elements, and this is available in the website. We will go through it, take a few case examples as we go along. These are the 10 chapters which have already been dealt with. Let us look at the first one, which is access, assessment, and continuity of care, which indicates that the eye care organization should definitely define the scope of its services. It should be absolutely defined, should be known to everybody working in the organization, and it should be displayed so that the patient, even before he enters the registration counter, knows that what this organization is able to provide. Can you give me a minute? I have some problem with my PowerPoint. Is my screen visible?
Not yet, ma'am.
No, ma'am.
So meanwhile, we can request the audience to share their questions in the chat box so that after the end of the session, we'll take some questions from the audience.
Well, can we go to the next speaker? Madam, let Madam.
to the next speaker. I have some problem in sharing my screen.
It's okay, madam. We'll have it.
Okay, ma'am.
I will leave the meeting and rejoin it.
All right. So we'll have some inputs from Dr. Ravindran. Madam started with the benefits for the organization. And since many of your hospitals are already accredited, some of them entry level, some of them going for ICAT standards. As a head of the institution, how do you feel, sir?
2009-10, the kind of the pressure of getting NABH was becoming more and more because some of the insurance companies and also the CGHS saying that becomes mandatory. So that's a point of time, as ICAR organizations, we made a joint appeal to the NABH that we should have a separate standards, because many of these standards we could not comply with that, especially in terms of nurses, especially the paramedical manpower, we were not able to comply, and there are many other things in the standards which we have to, even though it's not relevant to us, we need to create some evidence or documentation or go through that process. I mean, based on that, we had made an appeal. And subsequently, AAOS also took it up. And again, as Rajiv mentioned, it's a full involvement of Nirmal, we were able to do it. I mean, there are about 7 or 8 members. I think 5 of us are here. I think we had several meetings. Like Nirmal used to conduct these meetings regularly at Delhi. And collating all that information, putting it together and making it easily practical for the ICAR organizations to implement them. It's taken a lot of pains. I think now it has become a reality in 2017 after about 6 to 7 years of persuasion, at least about 2 to 3 years of work. And it has come out well. And I think ICAR organizations are the only specialty which have it. And it has been really made simple for any ICAR organizations to get it. The only thing it may lack is the efficiency, because ICAR is a very high volume field. There are some, it really doesn't look at the efficiency element. Now, how do we do more with less? So, and again, it's also about cost effectiveness. These two things are not addressed in the standards. So that is where you may have to decide whether you want to go with ICAR organization standards, which is like only full accreditation we need to go for. Or the other option, if you want really looking at efficiency and cost effectiveness, maybe the entry level part, which was presented, facilitated by Chandrasekhar, is the other opportunity. I mean, either one of that, it's ideally we should have it. And if you are single specialty, very few people are doing it, and it's good to have the ICAR organization standards. So there are some good things and some weaknesses are also there. Yes, Nirmal.
Thank you, sir. Thank you. Thank you so much, sir.
Can I join back in 9?
Yes, ma'am. Are you ready now?
Yeah. I'm really sorry about that. If you look at an ICAR center, every structure of the ICAR, standalone ICAR center is different from that of a small healthcare organization. The OT, Operation Theatre, which is the heart of the ICAR center, size of the OT, the air quality, the flow of men and material into the OT, the way in which the sterile and the non-sterile corridors are totally segregated, the number of barriers that we need before we enter the portals of Operation Theatre, autoclaving and sterilization techniques, the permission to use flash autoclave in between procedures, and especially in centers which has deals with posterior segment diseases, there should be a definite protocol for multi-dose vials, especially injection of Avastin or even local anesthetic. If you look at a daycare facility, which is a standalone ophthalmic facility, there is a lower nurse bed ratio. We do not require so much qualified nurses. In addition to that, we require certain other specialized staff members working with us, the refractionists, as well as the MLOPs. We also have permission for paramedics to apply eye drops, administer medications, prepare and assist in surgeries. And we actually require fewer qualified nursing personnel to perform procedures like assisting for general anesthesia and for the basic life supports. So if you look at the statutory requirements that are required for accreditation, we require almost similar statutory requirements: the building plan compliance for the NBC, the building plan approval by the town planning, or the TRIDA, which is the Trivandrum for us, which is the Trivandrum Development Corporation. The NOC for fire, certificate of fitness to operate lifts. We are controlled by the Drugs and Cosmetics Act if you're running a pharmacy, and the Shop and Establishments Act if you have an optical shop. But there is a little variation with regard to the biomedical waste disposal. Here in Kerala, we are all affiliated to the IMAGE, which is the IMA organization for biomedical waste disposal. We do not require facility for a sewerage treatment plant or an incinerator, but we do require a pollution control certificate. So the first policy, once the management has decided that they will go in for accreditation, is to set in policies, procedures, processes to assure that there is quality control, not only to assure that there is quality control at the time of accreditation, but to ensure that this quality is continued throughout. So if you're looking at, this is where I stopped. If you're looking at AAC1, let us look at AAC5, which are the laboratory services that are provided in the eye care center, which are a little different from what is provided in a multi-specialty hospital. There should be a specific policy for collection, identification, transport, and disposal of the lab material, manned by trained personnel. There should be a time-bound release of lab results and imaging prints. And it is also necessary that there is an official protocol to inform critical results to the concerned physician immediately. All this should be documented, verified, validated, and revalidated before the system is in place and the organization decides to approach for NABH accreditation. If you look at AAC 1, which states that the patient should be absolutely aware of the scope of services before he enters the portals of the hospitals. It is important to define the scope of services, have it included in the Apex manual of the hospital. The hospital should have manpower, equipment, and facilities commensurate with the defined scope, and there should be a permanent bilingual display of the scope of services in the registration area. It is also important to have staff who are aware of the scope of services and staff who have adequate training to carry out whatever we claim to do. If you look at the care of patient standards, there are various standards. The care of patient is uniform, established, safe, with very good final result for the patient. If you look at the COP8, which is documented procedure for administration of anesthesia, the policy should lay down checks at 3 or 4 different points so that the eye that is operated on is the correct eye, the correct medications are applied, the correct procedure and the correct surgery is done for the patient. And if we have this checklist in place, it will ensure that medical negligence is hardly ever thought about. Regarding the management of medications, most of this was covered by Dr. Chandrasekhar. There should be a definite policy to verify high-risk medication order. For example, there has been incidents in some of the hospitals in Kerala where like-sounding medications, high-risk medications were administered wrongly to the patient, especially when you stock succinimide, which is methyl prednisolone acetate you give IV as a bolus injection for retrobulbar neuritis, and scoline. There has been instances where the medicines have been wrongly given, and there should be a policy in place to verify that the high-risk medication order is verified before it is dispensed. If you look at the patient's right and education, it is very important that the patient is totally 100% counseled on the procedure that you're going to do on the patient, which eye you're going to operate on, especially if the patient has a bilateral disease, which eye is going to undergo the surgery, the type of procedure that you do, whether there will be any attendant procedures during the course of your surgery, which may require additional expenditure, the final prognosis for the patient, as well as the cost, has to be explained very correctly to the patient in a language that he absolutely understands. Hospital infection control is another standard which has to be mentioned, and the eye care organism should have in place a very efficient method of seeing that hospital infection control is maintained. The continuous quality improvement, whether structured quality improvement and continuous monitoring, structured patient safety programs should be in place, and the eye organization identifies key indicators. The key performance indicators have already been discussed, and it's a little different when the eye organization is concerned. The responsibilities of the management should be very well defined. The management should be willing to invest in time and funds to form a core team. Once they decide that the organization is going in for accreditation, and this core team should train the other staff members, should do the internal audit initially, and then go in for the assessment. The facility management service is absolutely important to ensure that the organization has the safe premise in which the patient can come in. The lift service has the certification that it is safe. The floor should be trip-free. All the equipments that we use should be properly earthed so that the patient does not receive a shock. These are all very, very small things that we have to look into before we go for the assessment. The resource management is very important. We should know that we are governed by very, very, very severe laws, which are both morally and legally binding. The code of conduct for the medical practitioner is very, very strict. So we should have a staff which follows the ethical code of conduct, knows that we are governed by laws. When ultimately the IPC, the Indian Penal Code, may also come into view if there is anything wrong in the behavior of the staff. The information management system is documented policies and procedures should exist to meet the information of the care providers, the right to information on the part of the patient to know what treatment that he is receiving. Once you have done this, the core team trains the existing staff members. The core team usually will have 1 or 2 members from each department at the hospital, for a senior and a junior member from this department, the hospital, who sits together for 2 to 3 hours per day initially before the assessment. They formulate what has to be done, put it in place, see to it that it is implemented, reassess themselves, and see where the confirmation is not occurring. They confirm themselves and they go in for the accreditation. The accreditation procedure is almost similar to what Dr. Chandrasekhar has said. The assessment may be on-site, desktop, remote, or a hybrid assessment, and you get a certification saying that your healthcare organization is accredited once you have cleared all the non-conformities. Once you have received the certificate, that is not the happy ending of your journey. You have to see to it that whatever you have claimed is enforced and you continue to doing it. There are focus assessments. This is the website which gives you the details. There are surprise assessments in response to an adverse event that occurs in your hospital. And the guidelines for using the accreditation trademark is very, very specific. The organization has to enter into a standard agreement with the the regulatory body. And if your required fees is not paid on time, or there is any adverse action taken up by any regulatory body against the eye care organism, or if there are serious patient issues, your name is taken off the list of accredited organisms. That is all that I have to say, and I thank you very much for your patient hearing.
Thank you, madam, for that wonderful lecture. You've really covered the entire spectrum of eye care standards from NABH as well as SSC point of view. So we'll move on to the next speaker. Since we are running short of time, I invite Dr. Agilan Arunkumar, PhD, Assistant Director, Operations and Quality, and Head of NABH Consultation Division. He is also a certified quality implementer with the Health Sector Skill Council. He has 20 years of experience in QMS, doctoral research and process performance in eye care, and he heads the Joseph Eye Hospital Administration Department. Dr. Agilan, please. So he will be talking to us about the difference between eye care standards and the entry-level standards.
Thank you very much, sir, for this wonderful opportunity. And I also thank on behalf of Joseph Eye Hospital for the KSOS for this thing. We started our journey with the general standard for hospitals. Then we downgraded to the entry-level standard when it was available. Once the eye care standard came, we also again upgraded to the eye care standards. So we have the experience of dealing with all the 3 sets of standards. And the entry-level standard is the easier step to venture into the accreditation process. So you have a taste of what is accreditation and implementing a quality management system. And it also gives you a sense of achievement once you've done that. After that, you have an urge towards improving it continually. That is what continual improvement is called. And here in NABH, we have the eye care standard, which is generic and specific to our eye care organizations. If you see the difference between the entry-level SHCO standards and eye care standards, it's about the standards and objective elements have doubled. So which means it's a leap. But since we have the architecture in place already, it is easier for us to take it further. And I encourage every entry-level accredited organization, certified organization to take care of the eye care thing also. The gross differences are one is with the statutory requirements, and then operation theater. In entry level, you don't need to have an laminar airflow with a HEPA filter and all the system, whereas in eye care organization, you need to have that. And with the human resources also, there are some guidelines which we need to follow that. The layout of the operation theater, the assessor, they don't go very specific into it. However, in eye care standards, they are particular about that. Yeah. With respect to the statutory license, the Clinical Establishment Act is mandatory for both the things like biomedical waste license, concerns under Water and Act, drugs and pharmacy. Building plan approval, if your buildings are a little old, they don't insist on that in the entry-level standard, but in eye care, they insist on getting the building plan approval or ratifications like that. Similarly for lift license and fire NOC, of course, with the third party thing, they NABH accepts at the initial stages, but you need to have a fire license or a NOC at the eye care level. When coming to the standards per se, in the first chapter, Madam has given an overview. I'm going a little deeper into the differences between those two sets of standards. Non-availability of process and procedures for non-availability of beds is there in the eye care standard, because we are dealing with a lot of camp patients. Suddenly we may have an influx of patients. So in that case, what kind of infrastructure that we have prepared and how much staff we will allocate, these kinds, these procedures need to be addressed here. Similarly, in the entry-level standards, the initial assessment should be completed within 24 hours, whereas in eye care, it is within 2 hours, because ours is predominantly a daycare nature procedures. Coming to emergency services, the entire triaging procedure need to be implemented in eye care emergency room. And the CPR is a new addition. Although some assessors are looking to the CPR code blue drills in the entry-level standard, it is a standard per se, it is not there in the entry level. But here in eye care, the entire resuscitation, how we train, update, and how do we monitor, improve the CPR is included here. And coming to COP, the care of vulnerable patient is not there in the entry level, whereas the entire set of standards and how do we, because most of our patients are geriatric patients, so they come under the category of vulnerable patients. So we need to provide the cots with the safe rail, the bathroom, non-slippery tiles there, and also the assessment process for the vulnerability of patients. And staff need to be trained. The consent process is also included under this category. Under pediatric service, almost everything is the same. The last standard, the children, family members are educated about nutrition and immunization is removed. I appreciate people who have worked on this standard, because this is a kind of a little irrelevant to the kind of service that we provide. Parental sedation is an addition in the eye care standard. It's almost similar to the anesthesia standard, except it is the monitoring parameters are little less in the parenteral sedation. In the surgical procedure, lasers are also considered as under the surgical procedure. So any quality assurance program that we follow for the surgeries should also have a similar program for laser thing. And a good thing is sharing of consumables have been included in the eye care standards, because in eye care, we share a lot of consumables between patient, and RDR sir has rightly pointed out that the cost efficiency should also be considered. And this is one standard that we need to really work on, bring on the guidelines. Hello. Sir, am I audible?
Yes, your slides
Yeah, you are audible, Agilan, but you need to share your slide. Resume slideshow.
Yeah. Sharing of consumables, which gives a lot of leverage for us to work on that, and we need to have procedures and protocols for that. And the organ transplant program is an addition in the ICAR standard program. For us, eye banking and corneal transplant program has to be guided by the guidelines given under this standard. And research activities, since ECO standards is a kind of full standards, entire research activities are governed. We need to have an SOP or a manual for research. We need to have a full-fledged ethics committee, informed consent, the right to withdraw from the researchers are all covered under this section. Coming to management of medication, the verbal orders, a lot of time we give telephonic orders, and there need to be a procedure like repeating procedures, and all these are covered under the verbal orders. And coming to MOM 3A, in the entry level standard, it says those are permitted by law to do so. Earlier it was those are licensed to do so. So now it is become stringent little. And patient's own medication policy. A lot of time patients bring their medication, own medication. How do we manage that? How do we store them within our purview? Who will administer, whether the patient will administer or we will do it, that is given here. The other important thing is multi-dose vial. There is a leverage given here. Intravitreal avastin, we do use it as a multi-dose vial. Our anesthetic drugs, we use it as multi-dose vials. And we need to have a good procedure so that this thing is also covered. So we don't need to have one patient, one drug policy. That and adverse drug events in the entry level standard, it was limited to monitoring, whichever we need to have a KPI and monitor that. In the full standards, we need to take corrective preventive action. We need to do a root cause analysis, and the entire second section of the process improvement is included here. Medical gases is a inclusion here in the ICAR standards. How do we procure, handle, storage, the replenishment factors, and safety, alarms, those kind of things all are there. Records we need to maintain with respect to medical. And consumables and implantables is an addition again in this ICAR standards. For us, the IOLs are all comes under this standards. Most of us follow what the guidelines says, but this is an additional standard as per the ICAR standards. And coming to PRE, which is patient rights education, general consent is introduced in the ICAR standards. However, in the 5th edition, I couldn't see the general consent term. So before implementation, you should check whether it is really needed. And list of situation where informed consent is required is also addressed in this chapter. And patient feedback and redressal of compliance is an addition, which is a good thing for any organization to improve their quality and care. How do we capture, how do we address the compliance, and how do we go back to the patient and tell that we have taken their input seriously is addressed there. And system for effective communication. We, for example, the acceptable and unacceptable communication should be defined clearly. Staff should be trained. In case of eye banking, the grief counseling is also governed under this chapter. Coming to HICs, we need to have an HIC committee which covers and coordinates the entire infection control program. We need to have a designated individual. It could be a nurse, it could be an infection control officer or a technician. Under the HIC manual, we need to list the high-risk areas. We need to have an antibiotic policy, which is missing in the entire entry-level standards. And if you have a kitchen, you need to include the kitchen under the HIC manual scope, engineering controls and housekeeping procedures. And in HIC 3, the standard requires we need to monitor the hand washing compliance as per the WHO checklist. And for sterilization activities, it is an addition. Reprocessing of instrument is given here. We use a lot of phaco tips and sleeves, which are single-use devices. But if we could have a clear-cut and false-proof method for reprocessing them, we can use it, say, up to 10 times as per the US standards. And there need to be an established recall procedure also for sterilization failures. And we need to have a multidisciplinary committee for quality improvement. And patient safety program is an addition in the ICAR standard. We need to have a safety officer in addition to the quality coordinator. And patient safety goals like the international patient safety goals need to be implemented in our organization. In the entry-level standard, the prescription of standards were not given, whereas in the ICAR standards, the entire list of things that we need to monitor and improve is given. And the clinical audit is a new addition in the full standards in ICAR standards. We need to do at least 2 clinical audits a year where the clinical team participates and identify, and I think a program is coming after this presentation. I'm not going into that. Sentinel events is a new addition in the ICAR standards. We need to define the sentinel events. It has to be reported within the prescribed time. We need to analyze and take corrective and preventive actions. Coming to ROM, the management support for safety and quality should be evidenced with the budgetary allocations, how the committees are functioning, they need to be reviewed, and also the corporate social responsibility like the CAMS, the iBanking program. These should also be laid out in the ROM requirements. Coming to FMS, we need to have a maintenance plan for facility and furniture. Earlier, we had a program, a maintenance plan for our maintenance and for equipments and instruments. Here, for furniture also, we need to have a maintenance program. And also, the NIH recommends we implement energy efficient and environmental friendly practices are implemented. In HR, verification of new needs to be training and policy there so that across the program, so that there is a career path development for them. And we need to have a performance appraisal system also. This is a very new thing for us, credentialing and privileging of our medical and paramedical staff. For doctors, we need to see their degrees, verify that, and then we need to provide them the privilege, whether they can do surgeries, whether they can be in the OPs, that kind of privilege has to be done. Similarly, for nurses also, based on their qualification and experience, credentialing and privileging has to be done. And allied health personnel. This is where our optometrists, all other allied health personals come. So this is a boon for our ICAR thing, where we can bring in the other health workers also into it. Medical record audit is a new addition, and we already do it in entry-level standard, but here per standard it has brought in here. And that's all from me, the differences between the 2 sets of standards. I wish all the participants to have a very good journey towards ICAR organization accreditation. Thank you, sir.
Thank you, Dr. Akilan. It was a wonderful presentation, and you highlighted the a whole lot of differences between the certification program and accreditation program. Can we have some inputs from Dr. Matthew before we go on to the next speaker?
Dr. Akilan has beautifully brought out the fact that iCare is a full standard, not an entry-level standard. And in fact, it is having more objective elements and more standards than even the small healthcare organizations. So it is very detailed, and it looks at COP, the care of patients, the patient rights and education, and the infection control in much greater detail than the entry-level standards. And it also looks at human resources and continuous quality improvement with objective elements which are 3 to 6 times more in number than the entry-level standards. Thank you for that beautiful presentation.
Thank you, Dr. Matthew. And it's my pleasure to invite Dr. Kamala Mahesh. She is an alumna of Bharati Vidyapith Medical College, Pune, and post-graduation from Shankara Eye Hospital, both DNB Ophthalmic and fellowship. She's worked in various branches of Shankara Eye Hospitals and in glaucoma practice, heading the glaucoma services of Shankara Eye Hospital, Shimoga, for the last 15 years. She's also an NABH assessor for both entry-level and full eye care standards. It's a pleasure to have you on board, Dr. Kamala. She'll be talking to us about medical audit and clinical audit. Over to you.
Am I audible?
Yes.
And my slides are visible?
Yes.
Thank you, Dr. Nirmal, for the introduction. So I'll just take you through the process of medical audit and clinical audit. So when it comes to the full accreditation, there is one entire standard which is dedicated to the medical audit and clinical audit. And most of the times what happens is when we go for assessment, various things are passed off as medical and clinical audit. So in my talk, I'm trying to, hopefully I'll try to bring out the differences between what we do in each type of audit. Slides are moving. Okay. So coming to what is an audit. So audit is basically an evaluation of the data, documents, and resources to check if the performance of the systems meet specified standards. That's a very, very simple definition of an audit. So coming to what is the difference between the medical audit and a clinical audit. Medical audit basically is a peer review of clinical care of patients provided by the clinicians. So it is the documentation of the clinical care given to the patient as compared with the institutional standard treatment guidelines. For example, if the institute has a standard treatment protocol for acute conjunctivitis, whether the clinician has given the treatment according to that particular protocol which has been formulated by the institute is what is checked in a medical audit. So you could do a retrospective or concurrent analysis of medical records. Whereas in a clinical audit, what exactly happens is a review of the activity of all aspects of clinical care of patients by medical and paramedical staff. So it's a multidisciplinary approach. It measures the current patient care and outcomes against explicit audit criteria, which are called as standards. Now, with these standards, you should not confuse with the standards of your NABH. So these are the different standards. I will be talking about these standards in my subsequent slides. So basically, clinical audit is an introspection of your own clinical work. Now, many times when we go for audit, a medical record audit is passed off as a clinical audit. So what exactly is a medical record audit? So medical record audit is a focused activity that emphasizes on the timeliness, the legibility, and completeness of the case records. So even a non-medical person can perform this audit provided the person is given a proper checklist as to what has to be audited. And the clinical care aspects are not checked in a medical record audit, unlike in a medical audit. Whereas in clinical research, now many a times even the postgraduate theses are shown as clinical audits, but they are not clinical audits. So what is a clinical research? Clinical research addresses clearly defined questions and hypotheses using systematic processes to generate a new evidence. So use of completely new treatment or practice, use of control groups, placebo treatment for comparison, etc. would come under a clinical research. So between a clinical research and clinical audit, the clinical research asks what is the best practice, whereas a clinical audit asks, are we following the best practice and what is happening to the patients as a result. Now, clinical research requires the institutional review board clearance. Clinical audit may or may not require its institutional review board clearance. So coming to the medical audit, it is a planned program which objectively monitors and evaluates the clinical performance of all the practitioners, identifies the opportunities for improvement, provides mechanism through which corrective action can be taken. They sustain these improvements and plan future course of action. And healthcare workers, healthcare providers can identify their lacunae and make necessary correction in the patient care. Now, what is a prerequisite for any audit? It could be a medical audit or a medical record audit, or even a clinical audit. So you need a team of medical consultants who are committed to the audit process. So you need an audit committee. So there has to be a senior clinical consultant from other departments, medical records in charge, and terms of references have to be formed, just as it was discussed in one of the previous talks. So the roles of responsibilities of the members, meeting frequency, the quorum, etc., everything has to be decided. The reports have to be submitted to the head of the hospital, and the hospital operational statistics should be available, and the same should be standardized and analyzed. So this is nothing but the KPIs. So the types of medical audit which can be conducted in an institute is a morbidity audit, where you conduct that all the complications of some surgery, you can take it as a morbidity and conduct it as an audit. You can also conduct a mortality audit. On-spot medical audits, like concurrent audits, can be conducted, or a statistical audit also can be conducted to give a graph-like presentation of the activities happening in the hospital. Now, coming to the clinical audit. So what exactly is a clinical audit? It is a quality improvement process that seeks to improve patient care through systematic review of care against explicit criteria and implementation of the change. So though the definition looks very intimidating, but it's not all that difficult to understand. So what happens in a clinical audit is there's an audit cycle which comes into play. So you involve the team and you plan the audit, you agree on the standards and set the criteria, you observe the practice and collect the data, then you compare the performance against the standards which are available, you present findings and agree on actions which has to be done, and then you have a action plan which needs to be implemented and decide whether this requires a re-audit which has to be done. So the methodology which can be done is, the first thing is the selection of topics. So you have to involve the users, even the patients can be involved in this. Build an audit team, so they need to have a skill matrix to conduct an audit. IRB is not required, but it can be taken. And the topic which is selected for the audit should be of high cost to the patient or to the institute. High volume of the procedures has been done in the institute, or it can be high risk to the staff or users, or there could be some serious quality issues like common medication errors or re-explorations which are happening, which could be a good topic. So the priorities in selecting the topic, there should be good evidence which is available for conducting the audit. Preferably published evidence should be available, and the problem which is concerned should be amenable to change. Pertinent to national policies. In our case, it will be more pertinent to your NPCB activities, and it should be a priority for the institution. So you should select a topic in such a way which covers all these aspects. Now, when you're setting the standard for the audit, it should be set prior to the study, and the criteria should be based on objective measures, and the standard should be written as a statement. Criteria on which the audit has to be conducted should be very well justified, and the target should be set at a realistic level. Now, all these terminologies I will explain subsequently. The third comes is the worksheet preparation, which you have to make it very simple for the purpose. Only essential data should be collected, and a suitable sample size has to be decided. Probability of bias should be considered, and this should be discussed before the initiation of the clinical audit itself. Then comes the next part where you tabulate your findings. So where you prepare a master chart of the relevant findings. And then comes the interpretations, where the deficiency of the care is recognized, specific solutions are proposed, planned program is advocated for change, and an active feedback mechanism is initiated. And also, very important is that the audit has to be evaluated. So what can be audited? Now, I have just given you an overview of what happens in a clinical audit. Now, let's go a little bit into detail as to what can be audited. So the basic things which can be audited are the structure, process, or the outcome. So when it comes to structure, it could be man, money, material, space. For example, your availability of ambulance or equipment availability, all these things can be audited. Now coming to the process, actions and decisions which are taken by the clinicians, like communication, the assessment, education, investigations, the prescriptions, even the surgical therapeutic interventions, evaluation of the patients, everything comes into a process audit. It could be even a outcome audit, where a physical or behavioral response can be audited, like which are pertaining to interventions or a reported health status, level of knowledge, or a satisfaction among the patients. So all these things can be audited. Now, the most easy and the most comfortable thing which can be audited is the process audit, because we as clinicians, we know what we are doing, and we can easily audit all the things which are happening in the day-to-day activities of the hospital. So now next is, when we start the audit process, you have to define the purpose of the audit. So when you're defining the purpose of the audit, it should be something like this, that it says that you have to improve or to enhance, to increase, to ensure, or to change. So that is why basically the clinical audit is being conducted. Now, objectives are nothing but the steps which are need to be taken in order to assess whether or not the aim has been achieved, and objective has to be written as specific tasks which have to be undertaken. Now I will take an example. Say, let us audit the management of lens-induced glaucoma in a hospital. So now coming to the steps of the audit process, is it a good topic? Okay, so it may involve high cost in patients if they don't come at the correct time, they don't get operated at the correct time. So one procedure may lead to another procedure, so it may lead to high cost to the patient. High volume, yes, we do see a lot of lens-induced glaucomas. High risk, yes, if you don't operate the patient at the correct time, there is a chance of visual loss and many other problems associated with the raised intraocular pressure. Quality issues, yes, if this particular case is not managed properly, there can be serious quality issues. And is there a clinical evidence that this particular treatment leads to this particular result in LIG? Of course, there are several clinical evidences which are available. So what is the purpose here? What would be the purpose? To improve the care of patients presenting with lens-induced glaucoma. So what would be the objectives here? Whether these cases are investigated properly and whether they are treated appropriately. So when it comes to treatment, can we measure our treatment algorithm with an available clinical evidence? So this is what would be the objective of this particular clinical audit. So once you have the aim of the audit topic, then you have an objective, that is, are we investigating it properly? And then you have an objective which says that whether it is being treated appropriately. Then you start setting standards. Now for a good audit, you can set about one or two standards for each objective. Now coming to the standard of an audit. So when you say standard, it is made up of criterion and a target. So what is a criterion? It is actually the main body of the standard. It should be a clear and precise statement of care, use of words or phrases which mean that it is measurable, and it indicates the boundaries of measurement. That is the yardstick. Like example, there is a time frame or who it involves, etc. And the target is the simple thing where it is the percentage which has to be achieved. So coming to our example, so when we say 100% of the patients presenting to the eye emergency OPD with lens-induced glaucoma will be seen by a duty doctor within 30 minutes of reaching the hospital. So this 100% becomes the target and the rest of the treatment becomes the criterion for the objective. So this whole thing. Now coming to the duty doctor within 30 minutes of reaching the hospital, it is the yardstick. So this particular thing is bounded by these two things which are included in the audit. Now, how do we set the standards for the audit? So we have from base, that is the the bottom of the pyramid, where you say that I have been practicing for 25 years, 30 years. So I have seen in my clinical practice, this is what it was good. So that is basically your own experience. And the pyramid just goes up where you have clinical case control studies, you have cohort studies, then you have RCTs and the supreme evidences like meta-analysis or clinical practice guidelines. So you have to set standards which are published in black and white. That means published in some journals. You can also audit clinical pathways like integrated care pathways, like example, glaucoma treatment algorithms, multidisciplinary pathways of care, like in, say, for example, diabetes retinopathy, and critical pathways where endophthalmitis protocols are evaluated. So these are also very good audit topics. When you are selecting an audit topic, there will be always some exceptions which are there. So you should always see whether there are justifiable reasons for not providing the level of care which is expected. So the patient, for example, patient refuses to accept the care, or there are contraindications of medications because of which the patient cannot be given the care. And the consistence on exception should be decided prior to the audit. So coming back to our lens-induced glaucoma. So when we are setting the criteria, we say that has a comprehensive slit lamp examination been done, or and the second one is, has an applanation tonometry been done in all the cases. When it comes to the treatment part, was the patient given IV mannitol and was the patient given medications for immediate pain relief? So this is how you can formulate your criteria. Now standards in this, how do you say that 100% of the patient presenting to the eye care emergency with LIG will undergo a comprehensive slit lamp examination by a duty doctor within 30 minutes of reaching the hospital. So this is the entire statement which gives the standards, the criterion, everything is clearly explained in just a single statement. And the next one is 100% of the patient presenting to the eye emergency OPD with LIG will undergo applanation tonometry within 30 minutes of reaching the hospital. So this is the second standard. Now, when you are setting standards for treatment, say for example, same thing, 100% of the patient with LIG, and you are giving IV mannitol within 40 minutes of reaching the hospital. However, there is a exception here saying that the BP, if it is more than 150 by 100, we will not give mannitol. Something else will be done in these patients. So this has to be decided prior to the audit is selected for the, the topic is selected for the clinical audit. Another thing is also that the second standard for the treatment, what I said was you have to give pain relief. So whether it was given within 40 minutes of reaching the hospital, now here an exception could be patient is not willing for the injection at all, or patient is allergic to the included medication in the audit. So it is as simple as this. You put everything in simple statements and you have a standard, you have a criterion is there, and the whole thing you will get an objective. So after you have done all these things, you can decide the time. You can say that either you do it in 1 month's time, 2 months' time, or you decide a sample size. So 30 is a very, very comfortable sample size for a clinical audit. But if you see the NABH annexure, they have given a very good table on how to select the sample size according to your screening population. So it could be when you're doing a data collection, it could be retrospective or prospective, and you can decide the sample size depending upon the number of patients you are treating. And when you have got all the data, you can do your sampling methods. Any type of sampling method is okay, whichever you are comfortable with. Then you have your data collection form. It should be very simple. Yes, no, do not, no types. It has to be a tick mark type. Don't make it very elaborate. It should be easy to fill and collate the results. And when you are making the audit report ready, it should be in the following headings. So you should have a title page where it tells you the topic of the audit. There should be a background. So when I say that lens-induced glaucoma, so there should be a short background about what is lens-induced glaucoma, aims and objectives I discussed, standards I discussed, methodology, results, conclusion, and after the conclusion, you should have an action plan depending upon what was the result of the audit. Then you have your references and your appendices. So this is how an audit report should be presented. So once you have the audit report, you have the results, then it's time to bring in the change. So how the change happens is from a pre-contemplation stage. So there is a pre-contemplation stage where we think that probably the LIG cases in my institute are not being treated properly. Then you start contemplating, saying that probably we should do an audit to find out whether the LIG cases are following the standard guidelines which are published. Then you prepare for the audit. You have an audit team who will collect the data, who is going to treat, who is going to see how it is going to be treated. All these things have to be taken care of. Then you have an action after the audit comes, and now you know what to do. And then, of course, the maintenance. Now, implementing the proposed change. So you identify the problem areas, the potential causes of problems, how to overcome these problems, and which solutions are likely to be successful, and what support would be needed. And with all these things, you should develop a proper action plan. And then the most important thing is you have to do a re-audit of the whole process. Now, what happens in a re-audit? If you have set your standards for clinical audit and all the standards were met, so you repeat the clinical audit to ensure that it is maintained. If some of the standards were not met, now depends upon how you get your audit results. So after the action is implemented, you repeat the data collection only for the standards which were not met. Now, if most of the standards were not met, you repeat the entire process and see what went wrong where. And if you are not able to reach to any conclusion with the standards, then you have to recheck the standards itself. So to summarize, clinical audit appears very deceptively simple, and the current care is compared against set standards, and necessary changes in patient care is implemented in the healthcare setting. And it basically needs a very, very highly self-motivated clinical team. And once the process is understood and planned, this is the best way to check quality, improve care, implement changes, and improve the patient satisfaction. Thank you very much.
Thank you, Dr. Kamala. That was a quite difficult topic to cover in a short time. You made it look easy. Can we have some comments from Dr. Mohan before we go on to the next speaker?
Yeah, I think nobody else could have explained this topic as clearly and as elaborate as Dr. Kamala did. So thank you very much for that.
Thank you, sir.
Your effort. It was well taken.
Thank you,
I don't think I have got. I mean, everybody should realize that it is the increase the quality of the process, maybe time and maybe finances and definitely the outcome, and beneficial to the patients and the healthcare providers. The re-audit, as Madam said, is probably the most important thing in it. It is not it is not enough that you put in a process and initiate an audit and then conclude something, and then if that is not being practiced, there is no point in doing this exercise. So I think we can move on to the next topic. Thank you very much and happy Onam to all of you.
Thank you, sir.
Thank you, sir. And next we move on to the next topic on preparing for assessment. So that probably is a important aspect of NABH accreditation. So I invite Dr. Matthew Kurian to talk about on preparing for accreditation. He is currently the medical superintendent of Chaitanya Eye Hospital and assessor with National Accreditation Board for Hospitals. He has a post-graduation degree from St. John's Medical College and Ratan Tata Cataract Fellowship, and also advanced management program from Indian Institute of Management, Bangalore. So welcome, Dr. Matthew. Over to your topic.
Thank you, sir. I would like to rephrase the title of my talk as how I should have gone about accreditation for the last 12 years, knowing what I now know as an assessor in the last couple of years. I have no financial interest in any of the points that I'm talking over here. Dr. Meena has talked about who can apply. It's somebody who is currently an organized eye care organization that has implemented the NABH standards for a minimum of 3 years. They should comply with the NABH standards and applicable legal, statutory, and all regulatory requirements. Where do we start? The start is, I think, simplest. Go to the NABH homepage, click on accreditation. You will get the list of options there. Right down there is the eye care organization, and that is where we should start. Next, we go from there. When we click, we get this list of options, the documents for eye care organization accreditation, the general information brochure, the pre-assessment guidelines and forms, and the desktop surveillance assessment are, I think, 3 useful places from where you can move ahead. The general information brochure gives the path of the accreditation journey, and we need to implement for 3 months. Then we need to pay the fees, do a pre-assessment, which may be optional. 3 to 6 months later, we go for the final assessment. And 3 months later, if everything goes well, after 2 cycles of correction and preventive action, we can get accreditation. So the full journey can take up to 15 months for organization. But I think the key here is preparation. The better we are prepared, the better and quicker we can do the job. And if we are very well prepared, we can go for a rapid 3 months of implementation, final assessment directly in 3 months later. And within 3 months, after 2 rounds of CAPA cycles, we can get the accreditation. So how do we get prepared? Preparation for the quality journey is of the entire organization. As my former boss, Dr. Bhujang Shetty used to say, Our quality journey is only as strong as the weakest link, and this one involves the chairman to the watchman. The quality manager is a point person. Dr. Kumaran has mentioned, the issue about external quality consultants. Most of them just copy paste the jobs. What we need, if at all we are going for an external quality consultant, is somebody who will coach our organization, transfer skills and knowledge, and ensure that implementation and practice is good. If at all we are going for an external quality consultant, there is another constituent body of the Quality Council of India called the Nabh, which is the National Accredited Board for Education and Training. And these people try to implement the slogan of the Quality Council of India, which is to create an ecosystem for quality. And we have registered qualified practitioners from these who consult with organizations. So if at all you have to take an external quality consultant, get somebody who's NABIT trained. But I think the quality journey is something that we have to experience, we have to internalize. And so I think it is best that we try to do it ourselves, though it may be a little more painful and a little more daunting to think about initially. Preparation starts, get the eye care standards. The two excellent other resources are the guidebook to the standards and the annexures to the full standards. And these explain the expectations of the assessors when they are going to come to your organization. The final excellent one is the accreditation for eye centers, which is the CME, part of the CME series AIOC number 34. And this is several of the panelists here, Dr. Nirmal, Gagan, are all part of this. And they explain in great detail as to how to go about things. The NABH today does a lot of education and training. That is a website to go for the training and education programs. I think it makes it life very much easier if we do a program on implementation, where the SSEs can understand the NABH standards, implement them in their organization. And these programs are conducted by senior NABH assessors, so you can clarify your doubts with them. More recently, there is something called the Quality Connect, which is learning with NABH. These are free monthly master classes, which include key performance indicators, infection control, management of medication, document control, clinical audits, and quality improvement. And these are typical pain points for most organizations that try to implement it for the first time. There's an additional resource page on the NABH web portal also, where good guidance material is available. The first step is to create the team, steering committee, and it will make life much easier to implement if members of the steering committee, one person cannot do the whole job. So individual members of the steering committee go and attend the interactive educational detailed workshop. These are paid ones. Now it is all virtual classes, and every weekend there is something going on. So there is something on clinical audit, CQI, documentation requirements, etc. And so the steering committee members will become domain experts in individual aspects of the process of NABH accreditation. Documentation is very critical. If it is not documented, you can say that it is actually may not be done also. How and why to document? The webinars are there, the templates are there. That was also mentioned earlier in the presentation. The document hierarchy, the top one is Apex manual, and Gautam has covered this in detail. So the one thing that I want to ensure to mention is that we need to ensure that the end user is involved in the documentation. If the end user is not making the document or not participating in the creation of the document, then the document will not reflect what is there in practice. As eye hospitals, we typically have quick daycare in and out patients. So IP record is something which I found was a pain point. The IP record needs to have several of these things, all of these things rather. The discharge summary, I will touch it in greater detail. Hopefully, we will not need a death certificate. Pre-operative assessment and an admission record where there is a reassessment at the time of admission is something that we never used to do. The consent forms were always there, but it was a very generic consent form saying, I understand all the responsibility, all the things have been explained to me, risks and benefits have been explained to me. That is not adequate, and I'll touch that in a little more detail. The pre-anesthetic checkup was always happening, but a review on the day of surgery just before entering into the OT was not happening in detail. The monitoring during the procedure and the recovery discharge criteria to move the patient from the OT to a recovery area and from recovery to discharge was not proper. We almost never used to do a proper nurse's record, a self-medication chart. A lot of our patients, more than 50% of a cataract surgery list will be diabetic patients. Whether they are using any of those things, if they are spending half a day in the hospital, I'm sure at some point they may be taking some medication. That was not something that we were doing. The timeout was something we were implementing more in terms of completing the documentation rather than with the intent of doing it with the spirit of the timeout. OT record we were maintaining, but the post-operative record before discharge was not something that we were having. Lab reports, of course, we would often have. In the informed consent, in red, I have highlighted what were the pain points and what we needed to fix in my previous experience. So what is the patient diagnosis? What is the procedure that is inevitably covered? But who will perform it? And if a trainee, who will supervise that? That is not something that would come into the consent. What is the expected benefit and risks were not detailed in great detail. What are the side effects and complications was again something that needed to be improved on. Any alternatives to the procedure, the emergency contact number, and what we had to do was to include a disclaimer saying that we were standalone hospital. So systemic emergencies, we did not have an ICU facility. Patient signature would often be taken. The doctor signature would rarely be taken. And this is AAC 14 that deals with that. And it was often just a small squiggle, full name, date, time, and place, which is part of IMS 3, was not being done. The discharge summary would often only have the final diagnosis and some cataract surgery done, but the reason for admission, significant findings, investigations performed, and the results, the condition of the patient at discharge. What would often happen is that patient stable is a note, but we need to have a little bit more as to what defines stable. The medication often would not be in generic names, and all capitals as MCI guidelines would not be followed. Follow-up advice and what is an emergency? Like, is there redness? Is there pain? Is there loss of vision? And how and where to contact for an emergency would not be detailed in the discharge summary. OT notes would just include the procedure performed and the surgeon and the anesthetist. Details of steps of procedure may not often be there. The status of the patient before shifting, the stability criteria, documentation, often it would be a fellow or a junior doctor who would be making the notes. The chief surgeon needs to countersign this, and this is a medical legal requirement. The committees has been extensively detailed again by Dr. Kumran. Composition, tenure, etc. is always there in almost all the hospitals. The meeting frequency, quorum, and the agenda, the minutes of the meeting would be less well spelled out. Monitoring of effectiveness, the reporting pattern, and the action taken, these were things that we needed to work on, and these were pain points for us. The self-assessment toolkit has been discussed by Gagan. It's a valuable thing because it tells you where the gaps are. And if we follow this thing, we can make ourselves much better prepared. And if we take this seriously rather than as just a secretarial exercise, our external audits will be much better. This was something that was not done in detail by any of the other speakers. Two sets of interviews are there. One is a patient and family interview, and this would include things like the data of when the OPD patient has been asked to review, details about discharge, something on health education, quality of pain management. All of us use intraocular lenses as implants, so whether the details of the implants have been done, the knowledge of patient's right and responsibility, risk benefits, cost of treatment. This cost of treatment is usually a pain point for a patient, and that is a point from which litigation arises, and the options for complaint redressal. These are minimum things that an auditor is going to look at when discussing with the patient, and so we should be prepared for it. In the staff interview, handing over between departments or handing over between duty cycles is something that is always a lacunae. CPR is something that we can expect. Discharge criteria, vulnerable groups, these are all things that are going to be asked of the staff. And typically they will not ask your most senior, most or experienced staff about this. They will be asking probably a person who has joined new, and that will see what is the weakest link in the chain that you have. High-risk medication extensively covered earlier, adverse events and the reporting and action taken of that one. Quality communication skills is becoming more and more important now to prevent dissatisfaction from the patients. Infection control, induction training, all these are going to be checked. The assessor guide is a useful tool for a assessee to look at, because the assessor guide tells where the assessor is going to start from. So he is going to start by looking at the application form, and we should make sure that the application form is well filled. You cannot say 30 beds or 50 beds at the time of application, but then on the day of assessment realize that you have only staff for 10 beds, and then suddenly there is a change. This discrepancy alerts the assessor that there is a problem in what you are doing. The self-assessment report is again a starting point for the assessor. And if a prior pre-assessment has been done, the corrective action on those pre-assessment non-conformances is going to be this important. The pre-assessment, what are they going to ask for? They are going to look at the application forms, the quality of the documentation that has been done, the implementation of that quality, and NABH chapter, the 5th edition that is coming, is looking more and more at the quality of the implementation rather than just the quality of the documentation. And medical audit, detailed discussion by Kamla already. HR, again, the 5th edition is going to become much more involved with the quality of HR, housekeeping, environment, and discussion with the eye care organization on the final assessment. The desktop surveillance is similar to the HOPE. This is for the interim surveillance, and it gives you what all data to load, and this tells you that if you don't have this, you can't even think of going towards that. So what are they looking at? The registration with shop and establishment, the local authorities, biomedical waste, fire NOCs, organ transplant if you are doing penetrating keratoplasties, if you are doing an eye bank, the diagnostic. The other important things are, of course, the basic statutory regulations. PCPNDT, whether it applies for a B scan, is something that I would like feedback on from maybe Dr. Nirmal. And it's a good thing that we have a person assigned for ensuring that these things get renewed on time, and alerts are there when it is nearing the expiry. Forms and formats, these are the basic forms and formats that are there, and we need to make sure that this quality of complete form filling is maintained. The CPR form, the adverse event form, and the sentinel event form, we must make sure that root cause analysis, when the events happen, is done, corrective and preventive action is done. On the informed consent, I'm very fussed about documents where patient signature is taken, and I'm very fussed about documents that are given to the patients. So like the discharge summary. So their sign, name, date, and time, this is compulsory, and we must ensure that overwriting incomplete forms or different pen usage, etc. during this thing, filling these forms is avoided. Manpower details, we need to have a complete Excel sheet list, and specific to eye care organizations, the allied ophthalmic personnel credentialing and privileging will help a lot in making sure that our staffing requirements are maintained. We found credentialing and privileging something a challenging task to understand what exactly it was initially. Credentialing is making sure that we check the education and experience of the person who, for consultant or doctor. Other details that would be picked into that is the attending the CMAs, teaching, research activities, the registration with the regular medical councils, ID proof, updation of credentials. These are all responsibilities of the individual to do. And the HR department needs to verify these things, the degree with the university, the registration with the MCI, the experience with the referees. And this verification is something that our HR department has to be taught how to do. In privileging, we are looking at ensuring that we document and have a method of saying that who is capable of doing what procedure as an independent person in the clinical practice. And this can be done by a committee or the medical superintendent, depending on the size of the organization. So like, for example, we may say that a junior consultant can assess and admit people, can know how to do BLS, but may not operate independently. Specific credential requirements will be required for some things, temporary and permanent privileges, and we need to have a method of reviewing these privileges. The committees have been touched upon in detail, so I will not go into that. The audit details. What we found most challenging was to understand that the clinical audit is not the same as a MRD audit or a completion of MRD forms. So that was something that which took us a little time to understand. The non-conformities of previous audits and how to ensure that it is completed. Mock drills, fire, cardiac, code blue, this is important. Us being in Kerala, I think with last 2 years of experience, flood becomes a very important thing, and we need to have some format of doing that. Violence against medical personnel in today's environment is also important. And what we need to do when we are doing these mock drills is to look at the response time of the team, the variation from two drills, and ensure that there is a good team approach, create a safety team, firefighting, code blue, and hazardous materials team. Equipment details, calibration status is all quite a challenge. We need to have a good biomedical team to ensure that this is done and maintain a proper annual maintenance plan for preventive maintenance. Facility routes, we need to segregate our facility into what is essential and what is desirable and prioritize based on what is there. Our current online program asks for geotag time-stamped pictures of all these areas, and that is displayed over here. What I would like to share as I finish my talk is that quality is not a destination, but a journey. To take home, we need to spend time to understand the standards, create teams, disseminate the knowledge, training, implement it, focus on implementation, simplify and standardize it, have audits, continuous quality improvement through corrective and preventive action. Thank you for your attention.
Thank you, Dr. Matthew. I think you covered it, the entire aspect in a nice way. So making my job a bit easier. We'll have some quick input from Dr. Sasikumar before I start my talk. Dr. Sasikumar, please.
So you need to unmute yourself, sir.
Yeah. Thank you, Dr. Matthew. Am I audible? Yeah.
Yes, sir.
Yeah. Your talk has been very exhaustive, very elaborate. You've given a clear picture of the efforts needed by aspirants for ECO. I mean, it's not an easy thing. What you've mentioned is it's a difficult process, it's a tough process, but it is worth attempting the NABH accreditation on ECO. Thank you. I mean, since we are running short of time, I think we'll move on to the next topic.
Yeah. Thank you, sir. So once again, thank you, KSOS team, for this wonderful opportunity, and for all of you who has come to this stage of accreditation journey, congratulations. And basically at this stage, what you know is some tip of iceberg. What some might know, again, is floating on top. But what you really should know and what you may never know, so that is the unknown. That is the usual iceberg metaphor. This is what happens in many of the exams and assessment. So this is probably, we choose our joys and sorrows long before we experience them. And assessment and exam preparation is one of them. So if you feel that it is good, it's good for you. If you feel that it is a bore element, it will be a difficult process. As my previous speakers have told, everything is given in this wonderful resource called NABH website. So it's time you go through that before you really come to the proper assessment. There are 4 types of assessment: on-site, desktop, remote, and hybrid assessment. Dr. Chandrasekhar has already dealt with this. And again, there are 2 types, 2 stages of assessment: pre-assessment and final assessment. And eye care organization is allowed only 2 cycles of review of corrective action. These are some important points. Most of us, one day before the exam, become the most religious person on earth, and accreditation visit also not. So this is one assessment where you should not stress. So do your best and forget the rest, because most of the preparation happens during the previous 6 to 9 months. So generally, the assessment principles are basically, it is well planned and managed and conducted using established method and technique. So it's transparent, it's reliable and sufficient to your scope of services and size of the organization. And the assessment principles is objectivity and it's independent. So you can't really sort it over a few phone calls. And there is a systematic approach to assessment. So in any assessment, before we go to the organization, some of the work Dr. Matthew has already highlighted, it's been done. And the final assessment is on site. And so generally we send a schedule, assessment schedule. So the principal assessor sends it to the organizing, the assessment team, assessee team, so that they can prepare the work and also prepare certain work documents. So will this process be easy? No, but it's really worth it. So you have to be devoid of stress, tension, and anxiety before you go to this process. So there will be an opening meeting where the principal assessor will give you the introduction and purpose and scope of the meeting, the assessment process, what we are going to do in the 1 or 2 days of assessment, the plan of the assessment, and if your organization needs any changes or any special arrangement, we'll be taking over it through that. So we will also be covering all this thing during the opening meeting, the objectives and scope of the assessment, the whatever findings that has been done in the pre-assessment, and also the limitation of the audit process and also the confidentiality. And in the final assessment, we'll also be talking about the certain documents and the requirements of the guides for assessment. So basically, we will start with the assessment team introduction. So depending on the size of your organization, the team will be a single member team or 2 or 3 member. There will be a principal assessor who coordinates all these activities with the eye care organizations. Basically, the scope of services will be the standard through which you go, whether it's entry level or ECO standards, and all the applicable objective elements. There can be some non-applicable objective elements, for example, blood and blood products, or the organ donation if you're not doing a keratoplasty. So in that case, that can be non-applicable objective elements. And the scope will be as per your application. So it's very important that you write your application properly, and will also assure of the confidentiality of the process. So don't forget the scope of the present assessment, whether it's entry level or SHCO. So generally, the assessment will depend on the scope of the assessment. The final assessment and the next level assessments more or less would be the same. So there will be a document review, there will be interviews, and also a review of quality projects the hospital has undertaken, and also the effectiveness of monitoring, the surveillance and monitoring of the laid down policies. We'll also see the entire quality assurance program that has been implemented, and key indicators and their analysis, how you have started and how it has grown over a period of the implementation. And then we'll discuss our findings with you, and then present our findings as a report to the accreditation board. This is what actually happens on the assessment day, and schedule as per discussion with the quality management team, and staff need to be available in those places. and see to that patient care is not interrupted. We are not there to interrupt your patient flow and do only quality assessment. Your work has to go on as usual. And if there is an emergency or any procedure going on, inform us so that we'll be prepared or will be part of your team. And basically we'll assess the structure, process and outcome of the entire hospital, and we'll be noting the adverse situation as well as the assessment sample. And it's better you cooperate with the assessment team because it's a very short term time available for us. And also you have to inform your people that the aim of this assessment is not to penalize a person or a department, but to improve the quality of services. And all adverse event will be presented before the assessment team and NABH. So compliance, basically whatever all the previous speakers has enlisted, not only the statutory and requirements, but also the entire patient safety requirements as per the standards. The functions of assessor, basically people think we are there to conduct the exam and punish everybody there, but we are not there to punish or give some adverse revert or just raise in non-conformances. So we care for the organizations we visit, we assess, and we also want to add value to your quality journey. So we don't have any voting rights. So whatever decisions or the report is given is only by consensus. And we don't recommend any accreditation directly. So we just gather evidence and send the report to the accreditation board. And the board will contact the principal assessor and any team or any team member to know if there are any clarification or feedbacks about the organizations. Generally, assessors, we don't give any advice, solutions, or guidelines. In the earlier days, we are used to be a consultant to the organization because as a hand-holding process. But now a lot of hand-holding process, such seminars are going on. So most of the ECOs are really well prepared. But we'll suggest broad principles for taking further action, particularly closure of the non-conformances. And we also encourage corrective action, but the deficiency will be reported to the accreditation board. And guides are very important. They should facilitate the assessment and also get documents and also help in communications. And as previously they told, interviews the best way of assessing your organizations. 100% of the problems are known to your own staff. And we are very glad to interview the staff and also the various leaders of the organizations. And we will also request you to maintain time schedule and not contravening your protocols. If there are any protocols in your organizations, please tell us. And very, very important that you produce the documents and records in a timely manner and trying to avoid confrontation, because this actually spoils the mood of the assessment as well as reduces the time available for proper assessment. So there should be a facilitation of smooth and pleasant assessment. So on-site activity is basically collecting and verifying information based on all this interview, examination, observing and reviewing the documentation, and also examining the records and report. So what exactly we assess? One is the continued adherence of standards and requirements, and any change in documentation between the previous assessment and present assessment, and of course KPI, and also the adherence to the terms and conditions of accreditations. Particularly, we will be looking at the sentinel events, near miss and serious events, and see what action the ECO has taken based on the incident analysis. And records, very important in this assessment process. This has to be complete and correct and legible. Of course, the filing, storage, archiving should be there. And so when is the assessment complete? Not on the day of assessment, but when you answer this non-conformance report. By this time, you know about non-conformity and scoring. I will not go into the details, but generally non-conformities related to the management system, the clinical functions, the statutory requirement, all this has to be closed before you really, the report is put forward to the accreditation board. So in the end of the day, in the closing meeting, we'll be giving you the assessment summary. We'd also say that assessment is a sample of activities. Sometimes the organization is lucky to go with some serious errors. Sometimes that may be noted by the assessors. So there will be some errors due to sampling. And also, not every NC will be reported. Only if it is in association with a particular objective element or standard, it will be reported. And we'll also, to encourage the organization to go with the accreditation journey, we'll see some of the excellent aspect of the organization, and we'll tell them these are all really excellent. And we'll also give some report on what are the good activities and good processes and structures available in your hospital, and also tell a brief summary about what all to improve on. Particularly, most of the eye care organization will have something to deal with the OT, particularly zoning, flow, and layout, and also the process control in the OT with reference to safety checklists and consent signature, and again, clinical audit and quality indicator performance. So the way ahead in the closing meeting is to close the non-conformances and depute some staff and quality people to close those NCs in a proper way, and send the reports to NABH and to the principal assessor. And this is a suggested format for closure of non-conformances. What is the deficiency? What is the root cause? And what correction and corrective action the organization has taken, given. And you should also give objective evidence, hyperlinks for those formats. So basically, assessee and assessor, throughout the assessment, you need to manage your time and also help us manage our time. Stay on track, follow the schedule as given. And the post-assessment process is also very important. Rectify the non-compliances and investigate the root cause and underlying causes, and monitor the situation whether it is improving. And all this have to be sent to the accreditation body by mail, as well as now it is online process. And once it is completed, the accreditation board will go through, and if the NCs are closed effectively, they'll grant you the certificate. Then you can join for a celebration and reap the benefits. But it's important to continue the journey through focus assessment, surprise assessment, and surveillance and re-accreditation assessment. So that's an overview of the assessment day journey. Thank you all for your kind attention. I'm sorry we overshot the timing. There are any questions, we'll take it up now. Thank you.
Thank you, Dr. Nirmal. That was a very good presentation. And overall, we planned for 2 hours. It went on for 3 hours. It became very detailed program. So we'll have the discussion in another meeting, in a closed Zoom meeting, where people will ask questions directly to the presenters, selected presenters. I'm not going to trouble all of you for a fixed time of say 1 hour, direct instead of going public. Those who are really interested, there's no presentation, only question answer session. We'll fix a date later. So those of you who are interested, please contact me. I'll arrange the meeting sometime convenient for all the speakers, depending on the availability also. Thank you so much. And I request Dr. Mahesh to say a few words, our Honorary Secretary of Kerala Society of Ophthalmic Surgeons, to say a few words, concluding remarks. And most of the questions have been answered in the chat box itself. Thank you, Dr. Chandrasekhar, for doing that, saving the time for us. And Mahesh?
Yeah, thank you, Rajiv. As it was told initially itself, this is a priming session, like people who have started the journey towards NABH or who are planning to start the journey. This is a primer sort of thing, but covered all the topics extensively. And Rajiv's idea is a good one. Probably we can have a one-to-one chatting in a group, a close group later. Anyway, I don't want to prolong. I thank each one of the faculty. In fact, all of them are authority in this field of NABH and accreditation. So it will definitely be useful for all our members and who are planning NABH accreditation. And it will be available in YouTube for quite some time. So anybody can go through that. Before concluding, happy Onam from all of us to all the faculty and all members. Happy Onam. I think everyone will be busy. Today is Uttradam, tomorrow is Thiruvanam. So everyone will be busy getting the final things for the Onam. Happy Onam. Thank you, Rajiv. Back to Rajiv for concluding.
Let me thank all the speakers and the panelists, and a special thanks to Dr. Chandrasekhar. He coordinated all this for me. Thanks a lot, and Nirmal especially for conducting it so beautifully. And thank all the speakers and wish everybody a very happy Onam. Thank you so much for being with us.
Thank you, Dr. Meena, Dr. Rajiv,
Thank you.
Chandrasekhar, Kamla. Nice to be with you again.
Thank you, sir. Thank you very much.
Thank you, Dr. Meena. Thank you, Rajiv. Thank you, Chandru.
Thank you so much, all of you. Bye. Be safe.
Thank you.
Bye-bye.